So, a very warm welcome to this outstanding meeting today. In the name of the Leopoldina, I really heartily welcome you to this annual meeting of the class of the medicine. And we've chosen to pick a highly important and still very influencing topic that currently occupies medicine in all dimensions. You know that the COVID viruses are new, and they've really been tackling the medical systems over the world. And meeting the unknown really has put all the doctors of the world into a tremendous situation to completely begin with new studies, new measurements, new exchange on scientific results that came up with the disease. It actually made us clear that we need a good scientific understanding of what's going on, and that medicine by itself is not only medicine, but a scientific field, and only the science behind it actually made it possible to address the disease and find solutions. It actually brought up an international intensified exchange between scientists and doctors of how to treat and save lives. And in this unprecedented situation, it now gradually, over the past 3 years, becomes clear that this virus is unique in touching different and various organ systems. So with this meeting today, we've been trying to get together all the scientists that are specialists in particular organ systems, and we're very happy to have brought forward a program where we can really address several of those questions. We still think that we're safe, pandemics seems to be over, but the border between it starts again or we have really reached a point where we can handle it is very, very critical. And I think over the day you will get to know this. And how close is it that things are getting out of control? So we need to work together. This forum, Leopoldina, is such a perfect forum to get all those scientists together. And I really am looking forward to this interesting day. I would like to start with our first speaker, and this will be Dr. Christa Scheidt-Nave from the Robert Koch Institute from Berlin, speaking to us on the epidemiology, like what is the virus, which path has the virus come from, and like what is the epidemiology of lung and post-COVID syndrome in Germany. So please come up.
Good morning, everybody. Thank you very much for inviting me to this wonderful meeting. I was asked to talk about the epidemiology of long post-COVID in Germany, and I would like to do that in 3 steps covering 3 issues. First, shortly talk about the challenges in epidemiological research on long post-COVID in general. Then take a look at the data from Germany in an international perspective. And then, of course, lighten the evidence gaps and perspectives, how we are going to close them, how we could close them. There is no doubt that long post-COVID is an emerging public health problem. We look at so far unexplained multiple post-acute health complaints, health symptoms after SARS-CoV-2 infection, in people after SARS-CoV-2 infection. And this appears not to be limited to severe courses of disease, to people who are in the hospital or in ICU care. Similar to other post-viral or post-acute infection syndromes, these are complaints that affect many organs, and we know this from influenza and other viruses, Epstein-Barr virus, but we didn't realize the dimension until SARS-CoV-2 came along. And of course, this is an individual and societal impact of huge immensity, but unfortunately, as we know so little, we cannot quantify it really well at this point. So this brings a high pressure into epidemiology, because epidemiology is really important to describe a problem, especially if we don't know very much about it. We need data on prevalence, incidence, health impact, on people, on society, and we need data on the natural course of disease. How long does it go? How many people do recover? When do they recover? All of that. And we need data on risk factors, protective factors to do something. And of course, we need knowledge about specific healthcare needs, and we can only get that if we look at people. So you probably all know that we work with provisional definitions. Early on in the pandemic, the British Institute of Healthcare and Care and Quality and Excellence, NICE Institute, came up with some guidance. And they said, look, we have this acute phase of 4 weeks, and symptoms that prevail afterwards, 4 to 12 weeks, we call long COVID. This is the name patients gave to the symptoms or to the syndrome. And post-COVID is whatever persists after 12 weeks. So that was helpful, but of course this is not a clinical case definition. Same thing, WHO, World Health Organization, came up with a preliminary case definition, first for adults in October 21, and most recently for children also. And they tried to, the expert panel in a Delphi process, consensus process, tried to precise it a little bit more, but of course this is also not a very precise case definition. So in consequence, we've been trying at the Robert Koch Institute to put the evidence together. In consequence, if you do not have a precise case definition, different studies measure different things, of course. Starts from the number, type of symptoms you ask people or measure, and it goes on with study methodology, design, methods, instruments you apply, and data sources. And this heterogeneity in results hampers to put the evidence together, especially if you want to do, like we need to do in medicine, meta-analyses. So all of this is, of course, we are struggling with that. Now, what data do we have in Germany? There is no ongoing monitoring of symptoms like we had with the corona infection survey in the UK. Some of you probably know that people were asked, tested people who were tested positive continuously in waves in the UK. They were contacted and asked about symptoms, whether they thought they had long COVID, what symptoms they had, whether these symptoms impacted their lives, and so forth, and then this was the basis for calculations. We do not have that in Germany. We have different studies, mostly at the regional level, and mostly these studies ran without a control group of non-infected persons. These are patient cohorts. Some patient cohorts selected presented themselves at university clinics. One of the first German studies in Cologne actually followed up patients that came to see people at the hospital because they had persisting symptoms. And those were people who were not especially sick. during the acute phase, but they had persisting symptoms and didn't know what was going on. And then we have population-based surveys and cohorts in Germany, mostly uncontrolled again, and those cohorts have been conducted with the health authorities, with the local health authorities who contacted people who were tested positive. They couldn't contact people who were tested negative, so there were no controls usually. And we have healthcare record data for secondary use in Germany, so that is another source. Now, the early studies in Germany helped to put the focus on type and frequency of symptoms. They had to do that because we didn't know much about it. And these studies, as I told you, of course, came up with very different estimates on how prevalent, how frequent was this among people who were tested positive, depending on who was studied, how long ago the acute phase was, and whether studies controlled for a low response rate, because of course not everybody took part in those studies. Depending on all of this, the range is wide, from 6.2% to more than 70%. But what was found very, very consistently, and you see this chart from one of the regional studies here, hospitalized people and non-hospitalized people, you see that the symptoms are much more prevalent among people with severe course of disease, and they are more prevalent in the earlier phase. They go back in when you have a larger distance of more than 12 weeks to the acute phase. And what was also very consistently found, women were more frequently affected than men. Now, the next steps in regional studies in Germany were cluster analyses. Of course, people wanted to know what's frequent, what's coming together, so we could help patients and look at patients who have specific combinations of symptoms. And it turned out on an international basis, but also in Germany, it was severe fatigue, cognitive impairment, dyspnea, and smell and taste disorders that were very frequent. But of course, this was not exclusive to these symptoms. There were many other symptoms, but these were particularly frequent. And from these clusters, one study, a regional study, again uncontrolled as part of the network University Medicine, that has a number of regional studies going on long COVID, post-COVID, they developed a severity score and tried to precise, for diagnostic purposes, of course, they tried to pick out people who were particularly severely affected by symptoms, and they came up with an estimate of about 10% of people, again, that might have a more severe form of long COVID, post-COVID symptoms. Now, what is really important is that the type of symptoms, especially fatigue and cognitive impairments, and the symptom severity really relates to lower quality of life and functional capacities. So that was the next step that was shown in the evidence. These were, as I said, mostly uncontrolled studies. Now we look at some very few controlled studies. One is a study that was conducted by the Robert Koch Institute as part of the acute corona monitoring. 4 municipalities in Germany hardly hit by the pandemic were visited, and people were invited and they were tested, and we had a follow-up of these people with varying follow-up rates, about 65%. Not too good, but not too bad either. And 4,000, way over 4,000 people were never infected. Remember, this is an early time, turn of 21, 22. And 350 people were definitely infected at baseline. And comparing the people with and without infection in this control study showed two things. First of all, quality of life was significantly lower in people with infection, controlled for comorbidities and all information what we had from those people from the baseline. And subjective health was definitely bad. Poor subjective health was definitely twice as frequent among people with infection compared to the non-infected controls. And same thing was for cognitive impairment, about twice as much of a likelihood to complain about cognitive impairment. So this showed control studies really can confirm that this is related to SARS-CoV-2, associated. It's not causally proven, but it's associated. And then the next step was a similar study, corona monitoring nationwide in Germany, that was a representative household panel study in nationwide monitoring of immunity status, conducted at the Robert Koch Institute in cooperation with the German Institute for Economic Research. They had this great panel, this great household panel running. And same time, about the turn of 21-22, there were standardized health questionnaires, antibody testing, self-testing. There was a specific method developed, and good tests were available at that time. And again, the proportion of people infected at the time was small, 8.6%, so not a very large group, but it was a control study who could compare people with and without infection from the same population. And what you see here is what you would expect. Out of the 19 symptoms, we asked them whether they had had it in the past 6 months, whether the symptoms were still persisting. 12 out of the post-acute symptoms were significantly more prevalent in people with infection. And if you look at the type of symptoms, you see what you would expect. It's fatigue, it's dyspnea, it's cognitive concentration problems, it's of course smell and taste problems. And we see a very, very consistent picture in this control study at the national level. Now, the question how frequent overall were symptoms, the prevalence of at least one post-acute symptom persisting up to present was very high in controls as well as in the people infected. And you can see that the difference is not really as high. It's 8.7%. It's not 56 like you would take from an uncontrolled study. It's 8.6. And this has been done in several countries, in the Netherlands, in Switzerland, and we all come up with similar estimates. We come up with estimates between 9, 10, 11%. And if you look at people who had symptoms with impact on daily life, execution of daily life activities, then of course this is smaller. Not everybody has an impact in daily life, but you see, again, high proportions in the population with and without infection, but the difference, 3.8%, also is in agreement with international large results from very large international studies. And from these data, you could, I haven't done it because I still think the numbers are preliminary, but I mean, not these numbers, but the calculation of how many people are there in Germany with long COVID, post-COVID. But you could calculate when we did, the population attributable risk and of course the numbers of people affected. Remember, these were people with mild disease, no hospitalized people. Now, the really, really important question is, who will recover and when? How long will it take when I have these symptoms? And again, there are few and widely varying studies from epidemiological population-based studies. Symptom-free at 9 to 24 months after infection are an estimated proportion of less than 50%. There are some studies, a recent study in Germany, a local regional uncontrolled study showed that the proportion was about 50% that still had persisting symptoms. And other studies, large population-based studies, multi-center studies have shown that this might be up to 90% people that recover and are symptom-free, excuse me. And full recovery, if you ask people, have you recovered from whatever you experienced during infection and afterwards, and have you regained your functional status, can you work, are you able to do things as you used to do before, then the estimates at 6 to 18 months, we really don't have good data on that, but the data that are out are between 65% and more than 80%. But still, I mean, if you think that about more than 90% and about more than 80% are large numbers of people recovered, you have to think about the large number of people infected, and these numbers add. And one last point, a large national study in Scotland, the Long COVID Scotland study, showed that recovery also is predicted by age, higher age, not really high age, but higher age means not the very young people, middle-aged people in mid-adulthood mainly. Females, women are less likely to recover than men, and the SMID is an index of social inequality in Scotland that is related or has been found to be related, and comorbidity, of course, and the severity of the acute disease. One last point, what about data that are there and could be used in Germany? A very difficult issue because we would love to use more data that are there, but it's very difficult to link them. Data protection plays a big role and should play a big role, but it is very, very difficult, and sometimes it takes too much time. But anyway, in the National University Network, funded by the Federal Ministry of Education and Research, it was possible to get the so-called Pointed Consortium together. That is a group joined or including 6 large insurance companies, statutory health insurance organizations in Germany, and then several healthcare research institutes and the Robert Koch Institute. And the first analysis we did in May 21, when we really needed data on children, on COVID and long COVID in children, we asked, do we see a higher incidence of diagnosis in children and adults based on those health records? And of course, we again compared people with and without confirmed infection. And it was a large group. I don't read the numbers, but it was a large group of people. They were very carefully described because we had healthcare data from 2019, so we had all the information before. People were matched. People with and without confirmed infection were matched. And there were 96 medical diagnoses selected based on literature and based on an expert round that tried to come up with core outcome sets. And what you see is, what we found is that the rate ratio, this is 1, meaning that the rate ratio between people infected and non-infected adjusted for covariables is similar, but actually in adults, all of the selected diagnosis groups or individual diagnoses were more incident in infected adults, and in children children are represented by the blue color. in children, it was not all of them, but many of them. So this was the first, one of the first studies in Germany. It was the first study that showed that really children may be affected, not quite as much as adults. You can see this by the absolute numbers. You can see that the children, the blue lines with the dark line indicating the infected, the rates among infected people, and the light blue, for example, is the line indicating the rate among non-infected people. And you can see that the absolute numbers are lower in children, but the relative risk ratio is very similar. Now, this study, or these analyses are going on, and right now we are trying to look how this is persisting, whether people get better, whether the diagnosis persists in healthcare records. And of course, we looked at specific diseases as well. And the first diseases we looked at were autoimmune diseases, for a good reason. You know that autoimmunity is one of the major hypothesized mechanisms in all this. And yes, we saw in a similar setup with a slightly extended database that adults, children, and different age groups, yes, autoimmune disease was more frequently diagnosed among people with previous SARS-CoV-2 infection. And the last two dots here, the last three dots show you that this had a dose response picture that we all recognize again. This was much more frequently seen in people after hospitalization or ICU care. Now, I'm coming to a close. Long COVID, post-COVID, what's coming up? And we have this large multi-center study from the US funded by the National Institutes of Health that did a good thing, taking together people infected over all waves of the pandemic from 85 sites across the US. And the really good thing was they involved patients, physicians, and communities. So they could come up with infected people and people who were still not infected, so volunteers that joined the study. And from a comparison of people with and without infection, they developed, again, a symptom score, but I have to say, the authors themselves cautioned, please don't consider this final. This is not the symptom score we can take out in our private practices and physicians' offices and diagnose people. But this is a preliminary score, but this is the way to go. This is to bring things forward. And there are, of course, ongoing large epidemiological studies in Germany. There is the National Pandemic Cohort Network I mentioned again before, in the network of University Medicine, and there is a similar initiative actually going on, bringing together physicians and medical centers and patients. And the national cohort, probably many of you know the German national cohort, one of the largest national cohort studies, of course try to bring in questions on long COVID in their recent follow-ups. And there is hospital-based COVID study, a large follow-up of hospital patients with and without SARS-CoV-2 infection. This is conducted by the Robert Koch Institute in cooperation with the Paul-Ehrlich Institute. And of course, vaccination is a big question, whether vaccination makes differences also in long COVID. We already could show that it makes a difference in severe course of disease. And of course, last but not least, there is post-pandemic health monitoring in Germany, and that is also conducted by the Robert Koch Institute. In summary, epidemiological studies in Germany contributed very early on to delineate long post-COVID as a public health problem and as a post-acute infection syndrome that we really have to take serious, and we know there are others. Prevalence and incidence of many long-term health sequelae are significantly higher among adults with than without previous SARS-CoV-2 infection. That was a very important step to show that. And the proportion of persons with full recovery is still not quantifiable. I cannot give you any definite numbers, but the absolute numbers of persons affected, even if you take the best scenarios, are substantial due to this huge dimension of the pandemic. Now, there are important open questions, some of the burning ones: what groups are at high risk, and especially groups, what groups or what people, who is at risk for functional impairment due to SARS-CoV-2 infection or in the aftermath of SARS-CoV-2 infection. What are the specific healthcare needs of these people, and how can we implement systematic assessment for improved diagnosis, prevention, and care? And ongoing population-based studies really have to strengthen the patient-centered perspective and include patients, and of course research in children needs to be harnessed. And we cannot go on in this without harmonizing outcome definitions, instruments, and also facilitate the use of the data that's already there that we really can use for secondary research purposes. And then finally, of course, this is, has been said over and over again, we have to join partners in epidemiology, healthcare services research, and clinical research. And with this, I thank you very much for your attention, and I would like to send a special thanks to the team at Robert Koch Institute and to our partners in research. Thank you very much.
Thank you very much for this beautiful overview. Are there questions? Yes, please.
If there is autoimmunity, we know from other studies that there is a kind of genetic background for autoimmunity. Are there genetic studies already to link genetics, autoimmunity, and post-COVID?
I'm sure there are. We haven't done it, of course. We couldn't do it in this study, but there are 2 British studies that have confirmed. I mean, this is not a standalone finding. And I think this is the way to go, to really go into deep phenotyping. And we have this beautiful network of university medicine, and we have the national cohort that can also go into deep phenotyping. And this is why I think we really need to work together, yeah.
Thank you for this excellent overview over the epidemiological data. Is there any possibility to consider or to exclude psychological factors? It means that a population that is informed by public opinion and by media, that there is a certain probability of developing symptoms like fatigue, like tiredness, loss of memory, that they are prone to have an increased awareness of abnormalities. Does this play a role? Is there a possibility to separate this influence on the statistical data, or do we have to live with this uncertainty?
Well, 2 things. There are 2 studies, again, from the network University Medicine, the COVID population studies that have shown that resilience, if you measure resilience in people, it relates. It's a factor. It's a predicting factor of long COVID symptoms. I think it's dangerous to say that it is a psychological issue or disease or problem. This plays a role, but these people are not feeling well, and if you ask them about their subjective health, it's poor. So, of course, if people do not feel well, they have psychological problems, and they may have had problems before, but this does not mean that this is a psychiatric disease or psychological issue that you could dismiss. If you have sick patients, you always are confronted with, what's physical and what's mental, and it goes together. For me, it's hard to separate, although it has been shown that it is an issue, yeah. One core variable.
Can I ask a question in between? If it happens that we're running into such a pandemic again, and you could do a wish, like what structural thing would have to change in Germany to run studies better? What should we actually prepare now to then have the tools that we need?
Thanks for this question. Comes from my heart, the answer. I think we need to harness the data structures. It would have been really good to have the health authorities, the local health authorities, in this from the beginning, and it would have been important to recontact people who were infected and who were tested positive, but also the ones who were not, and have early on data structures. And now we are trying to do all this backwards, getting back to people, asking them, what did you have and what did you have before? And of course, we need cohorts that go on. And there are some very smart studies that have put the data in existing databases. There was one study in stem cell donors, the register, and those are really, really good studies. So all of this data structure we need to prepare, because it's coming again, I'm sure.
Does politics know about your wishes?
Yes, I'm trying to let them know.
Yeah, one comment to what you said. I think one of the major difficulties with long COVID is the heterogeneity of this disease. Yes, there are some patients with autoimmune phenomena, but there are also some with endothelial damage, with other kinds of origin of the disease. And a little bit the difficulty is, for the same symptomatology, there are totally different etiologies. So what we need is big cohorts, well-defined cohorts, a standardization of the diagnostic procedure, and then from the biobanking, we have to have a deeper look into the inside of the disease. But I would think it's naive to think there's only one etiology and there's one therapeutic solution for the whole problem. This, by sure, will not be the case. It's a very difficult and complex issue. And one request from my side to the politics is we should not talk too much about long or post-COVID. It's a typical post-infectious disease syndrome. We've seen it before. So Carmen Scheibenbogen is working on chronic fatigue syndrome for decades, and there was no COVID. So it happens after EBV virus infection, after influenza. I've seen respiratory syncytial virus infections with long-term consequences very similar to COVID. We should change the name and take the focus away from this COVID debate. I think for the future in research, but also to set up structures, this is not helpful to do.
Thank you very much. Can I postpone the discussion to the coffee break? Otherwise, we'll not be able to manage with our program. Thank you very much again. And it's my great pleasure to announce the next speaker, who now, after after some initial technical problems, is online now, and it'll be Professor Amitava Banerjee from the UCL in London. And he's speaking on long COVID, from known knowns to unknown knowns. And I hope we can manage to bring him online now. Yeah. Perfect, thanks.
Also a consultant cardiologist. Thank you very much to the organisers for the invitation to speak. I have been thinking how to capture all of what we don't know, and I thought I'd use this very well-known expression that Donald Rumsfeld talked about when he was talking about the weapons of mass destruction in Iraq. So these are my conflicts. I'm a clinical academic. I have various research funders, and I'm a trustee of various organisations, including Long COVID SOS, which is a patient-led charity in the UK. So I think one of the problems that we have is one that's rife in medicine, that we work in silos, and when we have diseases that affect different systems, that challenge our communicable versus non-communicable ideologies, then we are stuck in our silos. So silo, for those of you who are classic scholars, is from the Latin and Greek, and that was how we stored corn and kept it separate in different pits. That we can't do when we're affected by a multidisciplinary, multi-system disease that is affecting different countries, and that falls under the realm of almost what we call complexity science. Also, the term pandemic has been challenged by many commentators that we should be talking about syndemics. Of course, the infectious agent, in this case SARS-CoV2, the virus is the key instigator, but to ignore the interplay of social determinants of health, of underlying risk in terms of non-communicable diseases and non-communicable risk factors is naive at best. So syndemic, I would say, is how we should look at this. This is what Donald Rumsfeld, the then Secretary of State of the United States, said. Said there are known knowns, there are things we know. We also know there are some things we do not know, but there are also unknown unknowns. The ones we don't know, we don't know. So let me try and use this classification. So known knowns. Well, we know that when I mentioned silos, these three silos of science, evidence, and care often sit totally separately. And whether it's brought about by electronic health record data or by ways of working, this learning health system concept of virtuously linking these three silos is incredibly important if we want to move quickly in this kind of cross-disciplinary challenge. The other known is that this sits on a prevention spectrum like other chronic diseases. So the best way to avoid long COVID is to avoid getting infected in the first place. That goes without saying. But most of our countries are now in a phase where they're not actively pursuing infection suppression. Vaccination is important as a primordial prevention strategy as well. But failing that, it's important to recognize people early, rule out other diseases and pathophysiologies, and try to treat symptoms and move towards a situation where we can actually treat underlying disease and provide rehabilitation for people who need it. This concept I've written about a lot in relation to my home territory of cardiovascular disease. So cardiovascular disease can be a risk factor, can be part of COVID and long COVID illness, and can be an outcome. And that fits nicely into this learning health system framework. So that's a bit of background for you. Now, in terms of the known unknowns, well, in the first wave of the pandemic, this is a pre-vaccination era analysis, and 40,000 people who were hospitalized with COVID and discharged. Yet at 4 months, 12% of them had died and 30% of them had been readmitted to hospital. And there was a good amount of new non-communicable disease, diabetes, MACE, which is major adverse cardiovascular events, chronic kidney disease, and chronic liver disease. This was published in the BMJ. But it's not just hospitalized. Remember, most people with long COVID in all of our countries are non-hospitalized. So their initial illness was not severe enough for them to be hospitalized with COVID. But again, this is analysis in the first 1,200 patients to go through our University College London long COVID clinic, where we see that the functional impairment, which the last speaker, my colleague, was referring to, the impairment that people suffer that's functional, that people are unable, even at 12 months, to return to work full time who were previously working full time. And there's people who were working before who are either retired or not working at all. So even the non-hospitalized group has a significant impairment. We conducted a study called the Cover Scan study. So with colleagues here from Perspectum, which is a company that works before the pandemic in imaging, particularly of the liver, but we developed a rapid multi-organ MRI sequence that can be done in 35 minutes and looks at all the organs except for the brain. And we were doing this in the first wave of the pandemic to try and identify if there was organ impact. And we showed that, again, one of the questions in the last session, that there's a large number of very varied symptoms. The good news is that a good proportion of people get better. So that's the dark blue bars. We followed people up here, I should have said, for 1 year. So 1 year, most people do get better, but a good amount of people still have symptoms at 1 year, whether it's fatigue, whether it's fever, whether it's joint pain. But on the bottom, there are various MRI metrics across different organs. And again, this is showing that although most of the abnormalities are mild, the dark blue bars are still present at 1 year. So there's persistent multi-organ MRI detectable abnormalities. And this study included 500 or so non-hospitalized individuals, and about 60% had single organ impairment, about 25% had 2 or more organs affected, and at 12 months, this was still present in about 60% of that 60%. So this is definitely a cause for concern. In my home territory of the heart, other than myocarditis, which is what most of the scientific community and most of the debate has been concerned with, even outside of myocarditis, 1 in 5 individuals with long COVID had persistent abnormalities at 6 months, and half of those at 12 persisted at 12 months. So on that backdrop, we set up a large national study called Stimulate ICP. The hardest bit in these kind of consortia is coming up with the acronym. I'll take the blame for that. But symptoms, trajectory, inequalities in management, understanding long COVID to address and transform existing integrated care pathways. So we you could say bit off more than we could chew here, but we, using those frameworks of the learning health system and the integrated care pathway or integrated approaches to prevention, we wanted to take a holistic view rather than biting off one therapeutic question within long COVID. And we did it like that because my co-lead in this project, Melissa Heitman at the top of the slide, is the national lead in the UK for long COVID services, but she set up the first long COVID clinic in University College London Hospital. And the model we have in the UK, when in England now we have over 100 clinics like this. So GPs refer people, GPs, the general practitioners, primary care physicians, will see somebody who's got suspected long COVID. If they think it is long COVID, they will refer to a long COVID clinic with basic investigations such as chest x-rays, such as ECG, such as basic blood investigations. They'll have a full assessment in long COVID clinic, and those that are able to will be referred for rehabilitation after other diseases have been ruled out. So the first work package is to look at usual care in this regard. The second work package is a complex intervention trial where we firstly are looking at whether the cover scan, that multi-organ MRI that I mentioned, helps inform and increase the efficacy of management of people with long COVID. And on the other side, we've got Living with COVID Recovery, which is a digital rehabilitation platform. So those two interventions are part of an integrated care pathway, which people are randomized to in a cluster design at what we call the primary care network level, so that it's part of their usual care. And within this study, we've also embedded a drug platform study, which initially had the antihistamines, loratadine, famotidine, but also it's got colchicine, an anti-inflammatory, and rivaroxaban, anticoagulant, in there. We are following people up for 3 months, 6 months, and then we have data linkage at 1 year, and they would carry on the therapy for 3 months. And fatigue on the fatigue assessment scale is the primary outcome, but we have a whole battery of secondary outcomes, both functional, psychological, and physical. I'll speak more to that trial a bit later on. And the third work package is about looking at inequalities in care for long COVID, from referral through to treatment, trying to improve the case finding and referral, because we know some groups and some components of the society are being missed, and comparing with other long-term conditions. This is just to say each of those three work packages has subgroups, and this is a big undertaking across many universities, hospitals, industry partners, and others, including policymakers. So there's epidemiology and informatics in the first work package. There's the trial both of integrated care and drugs. And in the third part, we have mixed methods approaches to inequalities, from interviews with qualitative methods to Delphi-style analyses. All of the protocols for these parts are published and available online, and you can go to our website. And we're gradually moving towards having results, definitely by the end of this year, if not early next year. So just to summarize the trial, so it's a cluster randomized trial of the integrated care components, i.e. the multi-organ MRI and the digital rehabilitation platform. That drug platform study is at the individual level randomization. There are 6 sites operating around the UK, and we're adding more sites. And this was done within the NHS system so that it can be scalable. It's not just a research study. And as my colleague Melissa Heitman says, that we did this because we're building the plane while we're flying it. Usually you know more about mechanism before you start this kind of drug trial, but whatever we find will tell us something about the mechanism as well. So that's why all of the drugs we've chosen, either drugs that the long COVID community of patients are already using and having some benefit from, but there's no trial data there. So there's the autonomic dysfunction, inflammation, clotting abnormalities, issues with mast cell activation. But what we are still in the hinterlands and the early stages of figuring out is what the underlying disease process is. Is it viral persistence? Is it immunology, inflammation? Is it a metabolic dysfunction picture? To date, we've recruited 800 people. We have over 300 in the drug trial. It's a difficult environment, not just in the NHS, but across health systems. But we're all recovering from a battering over the last 3 years, and that includes issues for our regulators, contracts, colleagues, and so on. So it's not easy to do research in this environment, but we still hope to have recruited over 1,500 people by the end of this year and be able to answer the question for these 3 drugs and for the integrated care pathway. And we're looking to add antiviral arms to this study as well, and looking for funding and support for that. There's lots of variation across the different clinics in the UK, even looking at the 6 that we're operating in terms of clinic design, patient flow, access. And that reflects that we as a health system, and I think that's across different countries, we're focused on the acute phase of the pandemic. And so whatever was left over was what we could tackle long COVID with, whether it's in primary care or whether it's in secondary care. And in the UK, we're lucky we have relatively good national electronic health record data. I'm coming towards the end, but I just wanted to show you some mechanism data that's quite new. So we showed, using data from the UK Biobank, that hepatic steatosis and fibrosis, independently of obesity and other risk factors, particularly metabolic risk factors, increase the risk of infection and hospitalization with COVID. And colleagues in our team have written about the link between the liver and the heart and the brain. Interestingly, when we look at our cover scan study in the first wave, we saw that there was a preponderance of liver impairment. If you look, about 30% of people, whether it was at baseline or at 1 year, had liver impairment, which is higher than what we'd expect in the general population. And in our interim analysis of MRI in the first 200 or so participants, we're seeing the same, if not higher, levels of liver and pancreas impairment. And we're looking at this further, and we're also looking in UK Biobank to see if there's any signal pre-COVID, because these patients obviously haven't been scanned before, but to see what was there before. But we've also got preliminary proteomics data to support this impaired liver metabolism picture. And so what we think of as a post-infectious disease complication, at least in a subset of people, there seems to be some metabolic process going on. And this is interesting because you may be all aware that metformin has been shown in the acute phase of COVID to reduce the incidence of long COVID. It's not been shown in people with long COVID to have any impact on symptoms as yet, but it's opening the door to thinking about metabolic dysfunction. On that theme, in our electronic health record analyses at national level, if you look on the left of this slide, this is 18 million people with COVID, and on the right, just under 300,000 people with long COVID. And we're looking at mortality and hospitalization over 2 years. The red lines are people with established cardiovascular disease. The blue lines are people without cardiovascular disease, but increased risk, be it hypertension, diabetes, or otherwise. This is assessed with this score called the Q-risk score. And what you see is that if you have cardiovascular disease, post-COVID, your mortality and hospitalization is astronomical. It's still high, even for the blue line. Interestingly, people with long COVID have low mortality, lower than the overall population, but they have a hospitalization risk which is similar to people with raised cardiovascular risk. And if you look on the right-hand side of the slide, just focusing on people with long COVID, again, it's people with cardiovascular disease and cardiovascular risk who have raised risk of mortality and hospitalization. So the chronic disease and post-infectious link is important. This is looking at the epidemiology of vaccination, and the red lines here represent people who are vaccinated. The darker lines are people. I'm sorry. The red lines are unvaccinated. The dark lines are vaccinated. So people who are in the red lines and unvaccinated have higher mortality and hospitalization in the COVID cohort. And the same is true for mortality in the long COVID cohort as well. This is just for the long COVID cohort, just a zoom in. And it seems that on the bottom, I'm focusing on people with cardiovascular disease. Again, if you're going to focus on a group, people who have cardiovascular disease and cardiovascular risk seem to have a poorer prognosis. There's a huge cost and resource implication of the millions of people with long COVID around the world. In our setting, we've looked nationally and looked at control populations. So the same people, historical self before the pandemic, people without COVID before the pandemic, people who had COVID but not long COVID, and the contemporary non-COVID cohort. And the only one that's more expensive to deal with at system level is the people who have acute COVID, and that's because of the admission and critical care costs associated. People with long COVID use a lot of healthcare resource, whether it's in emergency departments or general practice. There's that healthcare utilization occurs after the initial diagnosis of long COVID. It's not that it gets less necessarily with time. So that should put fire in our belly to do more research and more improvement to try to find out why that is and tackle this problem. So this is what I'm showing here across our 6 sites, that after the first long COVID clinic appointment, there's still healthcare utilization in both males and females. And this is a very complicated diagram deliberately just to show you that although I've talked a lot about electronic health records, part of the magic sauce is to try and draw out the patterns and clean the data. But here, what you're looking at is in University College London, where we have large-scale electronic health records. We've got vaccination rates, staff levels. We've got the political situation where a lot of our staff are on strike periodically at the moment. There's different resource problems in the system, and trying to superimpose what's happening with long COVID on top of that is not straightforward. So to finish, Chair, I mentioned the learning healthcare system. I think our science needs to be a lot more adaptive and increasingly the communicable versus non-communicable paradigm is out of date. We need to be moving from pandemic to syndemic. For our evidence, we need to be more data-driven and patient-led, and we need to be much more proactive, preventive, and patient-centered in our care. In the UK, there's various policy documents that are alluding to the role of the learning healthcare system. So prevention's best. We've got to zoom out and be wide angle, be joined up, and patient-driven is the only way. Thank you for your time. I'm happy to take questions.
Well, thank you for this really perfect presentation. Learned a lot. Are there questions from the auditorium? Yeah, please.
No, thank you. If you say prevention is best, we know so little about post-COVID. How can we do preventive action? How can we actually start preventive action at a given point? We have to learn much more to be preventive. Are there cues that you see to get into prevention?
Yeah, thank you. That's, of course, the million-dollar question. So infection and reinfection, as I said, things that we've paid less attention to at societal level now. But people who have long COVID, you'll see the people who are most likely to be wearing masks and wanting to get reinfected because of the fear of that. I think vaccination is what I meant. And I also hope that some of what I've shown you about cardiovascular disease and cardiovascular disease prevention are things that we have an evidence-based battery of treatments, both preventive and at the secondary prevention level, which have been neglected over the last 3 years because of health system pressure. Those are indirect effects of the pandemic. In terms of long COVID itself, we're still, so prevention is still in the evidence gathering, the trial stage. And I think we need more in the antiviral space, whether that's Paxlovid and other drugs to be tested. But I think also the metabolic data that I showed you, I would like to see more large-scale trials of some of the existing drugs that are used traditionally in the cardiometabolic space for people with long COVID as well.
Well, thank
the
you.
Easy answer is I don't know.
Thank you very much again. I think in the interest of time, we move on. And the next speaker in our program will be Professor Dr. Lisa Chakrabarty. I hope I pronounced it correct. On divergent immune responses in long COVID. She's working on the virus and immunity unit from the Institut Pasteur in Paris. And you need to get your laptop connected.
So, good morning. It's a pleasure to present our long COVID study to this distinguished audience. The study was done at Institut Pasteur in Paris, but I also wish to point out the role of our clinical collaborator, Dominique Salmon-Serron, who recruited the patients at Hôtel Dieu Hospital. And today I will discuss the adaptive immune response to long COVID. As we heard, there have been many possible mechanisms mentioned with respect to long COVID, and here are listed some of the major hypotheses. SARS-CoV-2 viral persistence is proposed to directly create tissue damages in sanctuary sites, for instance, in the brain, the gut, or the bone marrow. There have been signs of microbiota dysbiosis, which may contribute to gastrointestinal symptoms. Immune dysregulation is often proposed as there are often signs of herpes virus reactivation, in particular reactivation of EBV and HHV6. So this would point to a dysfunctional immune response that is not capable of controlling viruses. Autoimmunity, as we heard, may be involved. For instance, autoantibodies to beta-adrenergic receptors may contribute to problems in the regulation of the blood pressure. Blood clotting, abnormal activation of platelets, and endothelial abnormalities have often been reported, and we will hear more about that in the next presentation. And last, dysfunctional neurological signaling may account for brain fog or possibly dysautonomia. What is notable is that many of these mechanisms may be driven by abnormality in the immune response. For instance, SARS-CoV-2 persistence, EBV reactivation may derive from an insufficient immune response to viruses. On the other hand, autoimmunity, endothelial activation, platelet activations may derive from an excessive or dysregulated immune response. And it's possible that chronic inflammation also contributes to the neurological dysfunction. So there is a good rationale to look at the role of the immune response in long COVID. The role of T-cell response is fairly well understood in the acute stage of infection. The virus will start to replicate, this is the purple line, and then inflammation, the green line, will start, but it is slightly delayed as compared to viral replication because the SARS-CoV-2 virus is a master at evading the interferon response. Nevertheless, inflammation will start and will promote the development of the adaptive immune response, the T cells and antibodies that will help control the virus. Several groups, including those of Shane Crotty, Antonio Bertoletti, and Malameni, have shown that if, for some reason, the T-cell response is delayed or of low magnitude in the acute stage of infection, let me try to point. Pointing is a little difficult here. Then it's associated with a more severe COVID. And the group of Malameni has also shown that conversely, if there are pre-existing T-cell response to the polymerase of coronaviruses, possibly due to cross-reactivity between the responses to common cold coronaviruses and SARS-CoV-2, then the infection will be much less severe and will be even covert, may not be detectable at all. So the T-cell response is important early on. In long COVID, it's a little more complex. There have been reports of excessive adaptive immune responses in long COVID. For instance, the file studies have reported the persistence of a high frequency of spike-specific CD4 T cells in long COVID patients as compared to patients who recovered from disease. It may also happen within tissues because there is an inverse association between the presence of tissue-resident memory CD8 T cells specific for SARS-CoV-2 and lung function, pulmonary function. And Paniskaki et al. Have reported an increased rate of highly differentiated TEMRA CD8 T cells in long COVID patients as compared to recovered patients. There are also two large studies that have yet to be peer-reviewed by the group of Akiko Iwasaki and the group of Nadia Rohn that have reported higher antibody responses in long COVID patients as compared to recovered patients. And these groups have also shown signs of aberrant T-cell engagements, for instance, increase in exhausted CD8 T cells and also increases in CD4 T cells that express chemokine receptors that will enable these cells to migrate into tissues. So overall, there are signs of an activated but possibly dysregulated adaptive response in long COVID. Not all is simple, however, because there are also signs of an insufficient adaptive immune response, especially during the acute stage. 3 groups, including that of Clara Lehmann, have reported that low spike-specific immunoglobulins in the acute stage is associated with a higher risk of long COVID in the later time points. And there's also this group, Hugh et al., who reported that low immunoglobulins is, in the acute stage, is associated with a higher risk of viral reactivation in the 2-3 months following the infection. The group of Pierre Corbeau has reported that there may also be signs of a defective T-cell response in that CD8 T cells have a lower capacity to produce perforin during the acute stage in patients who later on will develop long COVID. And last, I will remind you that Su et al. Published several predisposing factors to long COVID, and one of them was the presence of SARS-CoV-2 RNA in the blood, in the circulation, which means that the virus could cross the epithelial and endothelial barrier, and that it was not controlled by the immune response. So there may be signs of an inefficient response early on that will then drive a dysregulated immune response at later time points. So to further address these issues, we studied 51 long COVID patients recruited at Hôtel Dieu, and these patients had either documented SARS-CoV-2 infection by PCR or antibodies, or they had probable SARS-CoV-2 infection due to the presence of at least 3 signs of acute COVID and the persistence of 3 signs of long COVID for over 3 months. And these patients had mild or moderate infection because they were not hospitalized. And they were compared to patients who had recovered from COVID, who had documented infection, who were outpatients, and who had no signs of recent reinfections. And there was also a control group of healthy donors who were either contemporary blood donors at Hôtel Dieu or who were pre-pandemic blood donors at Établissement Français du Sang. And it's important to note that all these participants had not been vaccinated at the time of blood sampling, meaning that we could study their responses without the perturbation associated with antigenic restimulation through vaccination. One point is that we chose to include among the long COVID patients some patients who were seronegative. The reason is that in the Persicor cohort, which was established early in the pandemic in 2020, about 1/3 of the long COVID patients were seronegative, which is quite a high rate. So we thought this was worth studying. But of course, the caveat is that infection could not be documented in all of these patients. Some were PCR positive, some had anosmia agusia, which makes the SARS-CoV-2 infection very likely, but about half of the seronegative long COVID patients only had clinical signs, but not a laboratory documented infection, which means that we could not completely rule out a misdiagnosis. But I would like to point out that, first of all, seronegative COVID infection is not that rare. I will take as an example that British study which enrolled over 7,000 patients who were PCR positive, and what is shown in this graph is the level of antibodies. In these longitudinal studies, they found 3 types of patients: those that seroconverted in red, those that were already seropositive at inclusion in brown, and quite a few that never seroconverted in blue, up to 24% of patients with a fairly high stringent threshold for seroconversion. But if you take a more usual threshold for seroconversion, there may be 10 to 15% of the patients who remained seronegative. And these patients tended to be older with a lower viral load and fewer symptoms. So seronegative infection does happen. And also, one reason why we included these patients is that often they face difficulties in getting access to medical care because they encounter skepticism. And we thought that if we could find some biomarkers or some immunological traces of infection in these patients, it may be beneficial for this patient group. Another important point is that the spectrum of symptoms was fairly comparable in the group of seronegative long COVID patients, LC- in orange, and in the group of seropositive long COVID patients, LC+ in purple. There were still a few differences in fatigue, but the most striking difference was fever. It was the most significant, with about 1/3 of seronegative long COVID patients who had febrile episodes, as compared to only 3% of seropositive long COVID patients. And I find this possibly interesting because fever may be a sign of viral persistence. So maybe there is more viral persistence in the seronegative patients. So the patients had been tested with a spike-specific ELISA at the hospital, and this is how the seronegative and seropositive groups were defined. But we thought it would be interesting to revisit the antibody response with a more sensitive assay. So to this goal, we used the S-flow assay developed in the unit of Olivier Schwartz, and this consists in incubating the patient sera with spike-expressing cells, cells which express spike at a high level. So what is detected is antibody that can bind to the native spike. Then this antibody binding is detected with a secondary labeled antibody. The cells are harvested and they are analyzed by flow cytometry. In this S-flow assay, we measure the percentage of spike-positive, of IgG-positive cells, and we could see that, as expected, responses were minimal in the group of LC donors, HD, that they were high in the group of seropositive long COVID patients, LC+, they were as high as in the group of patients who recovered without symptoms from COVID, in blue, airy, and they were quite low in the group of seronegative long COVID patients, LC-, though we noted a few patients with intermediate viral antibody responses that could be detected with this more sensitive assay. In terms of IgA responses here, the pattern was similar with low responses in the HD groups, low but with a few intermediate responses in the LC- groups, and more variable but similar responses in the LC+ and RE groups. Then we asked whether we could detect antibody response to other proteins. On the left, on the y-axis, it's the antibodies detected by Luminex to the nucleoproteins. And on the right graph, it's the antibodies detected to the matrix or the envelope proteins. And you can see that these responses were overall well correlated to the spike-specific immune responses shown on the x-axis. So the seronegative long COVID patients, shown with pink symbols, were seronegative both for the spike but also for the N, M, and E proteins. We then asked whether these patients could respond to coronaviruses more generally. So to this goal, we measured the antibodies to the spikes of the 4 non-human common cold coronaviruses, OC43, HKU1, 229E, and NL63. And overall, as you can see, we did not detect major differences between groups. There were a few signs of a higher responses to the OC43 spikes in the recovered patients and the seropositive long COVID patients, but they were higher to the seronegative long COVID, but also to the healthy donors. So we think that this is more a reflection of a degree of cross-reactivity of antibodies to the SARS-CoV-2 spike, which can also bind a little to the OC43 spike. Overall, we found similar antibody reactivity to common cold coronaviruses, meaning in the different groups, meaning that the seronegative patients were able to mount antibody responses to at least some coronaviruses. We then studied their immune response, their CD4 T cell responses using a primary CD4 T cell line assay. We use this assay because it's more sensitive. The principle is that you take PBMC, that you stimulate them with immunodominant SARS-CoV-2 peptides, and that you keep this culture in the presence of interleukin-2 for 2 weeks. And then at day 14, you re-stimulate the cell lines with the individual SARS-CoV-2 peptides, and you measure cytokine production by intracellular cytokine assay. So here you have an example of such an assay in a few patients that were re-stimulated with the M141 peptide, which is an immunodominant matrix peptide. On the top row, you have the cells when they are not re-stimulated. We do not detect a cytokine response, but upon matrix peptide stimulation, we could detect a strong response in these seropositive long COVID patients, both in terms of TNF-alpha and interferon gamma. The responses are massive because we amplify them for 2 weeks. And interestingly, we could detect a lower but quite detectable CD4 T cell response in that seronegative long COVID patients, CL4, meaning that this assay provided evidence that this patient had actually been infected by SARS-CoV-2. So here I'm showing the responses to the 3 matrix peptides we studied, M86, M141, and M176. And you can see that 2 of these peptides were quite immunodominant. We could detect responses to M141 and M176 in at least 80% of the seropositive long COVID patients, even though these patients had not been selected for a particular HLA-DR type, meaning that probably these peptides could bind multiple HLA-DR alleles. There was a trend for a higher response in the seropositive long COVID patients as compared to the recovered individuals, though this did not reach statistical significance. And in the seronegative long COVID group, we could find generally low or undetectable responses, but with maybe a few individuals who had positive responses. This was a little difficult to say because there were also a few responses above background in terms of TNF-alpha production in the healthy donors. But when we studied interferon gamma, the background levels were quite lower, so we could say with a better confidence that there were actually a subset of seronegative long COVID patients who had detectable CD4 responses. And sorry, yes. So we did this approach for the 3 proteins, the matrix, the nucleocapsid, and the spike, with a total of 9 peptides tested. And here I summed all the responses to these 9 peptides. And you can see the TNF-alpha response on the left, confirming that, first of all, we had high responses in seropositive long COVID patients, but they were not statistically different from those in recovered individuals. And second, that there were indeed a subset of long COVID patients with detectable CD4 responses, and that were higher than those found in healthy donors. Without going into details, we correlated the different parameters analyzed in the Persicot study, and I highlighted here in columns the antibodies to the different SARS-CoV-2 proteins tested, and in the rows, the CD4 responses to the different viral peptides tested. And you can see in the dark square that there are quite red colored squares, meaning that we had high correlation coefficients between the antibody responses and the CD4 T-cell responses when all the patients were grouped together. And it makes sense because, as you know, you need an efficient CD4 responses to obtain the maturation of the antibody response. Now, when we looked into more details, here I plotted the responses to the M141 matrix peptide on the x-axis and the spike-specific antibody on the y-axis. We have overall a good correlation, but you may note that the seronegative long COVID patients had more dispersed responses. Here you may see a group of seronegative patients with the pink symbols that had detectable CD4 responses but no antibodies. And there were a few patients with detectable antibodies but no CD4 response, meaning that the immune responses appeared less well coordinated in the seronegative patient group. And here we are looking in this table at the detail of the responses in the seronegative long COVID group. Highlighted in yellow in the first column are the patients who responded to at least 2 peptides in terms of CD4 responses. There were 39% of the patients who had at least 2 responses. The second column is the patients who had detectable IgG in the S-flow assay to the spike, and they were 22%. And we also had a few patients who had a detectable IgA. But you may see that patients with CD4 responses did not necessarily have antibody responses, and the converse is true, highlighting the lack of correlation between these 2 responses. But overall, if we take all the immune parameters into account in the rightmost columns, we can say that we have immunological signs of infection in 52% of seronegative long COVID patients using these sensitive assays. And if we add the patients who had a confirmed infection through PCR or those that had anosmia or ageusia in the acute stage of infection, then we can say that infection is highly likely in over 82% of the seronegative long COVID patients, meaning that these patients, for their vast majority, had actually long COVID and that they are worth investigating. So to conclude, we found a similar spectrum of symptoms in seropositive and seronegative long COVID patients. The seronegative long COVID patients had antibody and CD4 responses as high, if not higher, than those of the recovered individuals. In contrast, seronegative long COVID patients showed low antibody and CD4 responses. However, using sensitive assays, we could find traces of an immune responses in half of these patients. But there were poor coordination between the antibody and the CD4 responses in these seronegative patients. So in conclusion, we found evidence of divergent immune responses in long COVID with a group with very low responses and a group with high immune responses. And this, of course, raises the possibility of multiple etiologies in long COVID. And to summarize our current hypothesis, Well, in resolved SARS-CoV-2 infection, we have efficient T-cell and antibody responses that are induced at high level, but that will progressively decrease with time. In seronegative long COVID, we think we may have suboptimal T-cell immunity. That somehow these patients have maybe an intrinsic defect in response to viruses, or maybe they didn't, for some reason, they did not mount an efficient response at the time of their acute infection. And because they have suboptimal T-cell immunity, it's possible that the virus may persist at low level in sanctuary sites and drive tissue damage either through direct effect or through the persistent induction of the innate response, which may drive inflammation. And then, as you know, chronic inflammation is deleterious to many physiological functions. In the case of the seropositive long COVID group, we may also have suboptimal T-cell immunity, even though it may appear as high magnitude. It's possible if the immune response is exhausted and that the T-cells are not capable to lyse the infected cells. It may be due to, for instance, low TCR affinity for the SARS-CoV-2 epitopes, or alternatively, they may have if they have an inefficient T-cell immunity, then we are in the same case scenario as for the seronegative patients, possible of viral persistence and continuous inflammation. Alternatively, the seropositive long COVID patients may have efficient immune responses in terms of viral clearance, but for some reason, this immune response does not abate. And there is this immune dysregulation that would drive inflammation and tissue damage. So further studies will be needed to distinguish between these hypotheses. I will conclude here by acknowledging the people involved in this study. Jérôme Kervévan was a key person because he was a postdoctoral fellow in my group who did all the cellular assays. Isabelle Staropoli in the unit of Olivier Schwartz did the S-flow assays. The group of Michael White did the Luminex assays. Dominique Salmon-Serron and her team were our clinical collaborators. I also thank the people involved in flow cytometry, the methodologists, and of course the volunteers who took part in this study. Thank you for your attention.
Well, thank you very much for presenting this highly immunological topic in such a well-understandable way. Thank you very much. Questions?
Towards immunity, you've shown that there is an abnormal TNF-alpha response. And, yeah. Okay. So you've shown us that there is an abnormal TNF-alpha response in some of the long COVID patients. And for T-cell-driven diseases, you know that there has been anti-TNF-alpha antibody treatment, for example, for rheumatic diseases or also autoimmune diseases, T-cell-driven, like morbus Bechterew. Would that be an option? Would anti-TNF be an option in this case?
I would be cautious because we found in the seropositive patient strong TNF responses, but in terms of magnitude, they were not that different from those of recovered patients. But I should point out that the recovered patients had a smaller duration of infection, so we could not really make a matched comparisons. And I think that the immune response persisted for a longer time in the seropositive long COVID patients. But I would be cautious. I would maybe not try to inhibit the antiviral response because maybe this may cause viral resurgence. And we already know that some of these patients, they have EBV reactivations. So I would go slowly on the immunosuppressive therapies. It may be tested, but very carefully. I would rather try everything that is antiviral, especially in the seronegative patients. So we will see what Paxlovid is giving, while the new antiprotease inhibitor from Shionogi will give. Maybe other antiviral approaches can be envisioned. And in terms of immunomodulation, I would be a little more cautious.
Can I add a question? You mentioned that in the seronegative patients, for some reasons, that was your exact term, there's no T-cell answer eluded, so to say. Could you speculate what these some reasons are?
I can only speculate. We do not have data. I'm wondering whether there could be a subtle immunological impairment through genetic reasons in these patients. One thing I did not mention that I find interesting is that there are quite a high frequency of atopy in the long COVID patients, at least in the Persicor cohort. This remains to be confirmed in larger cohorts, but if it's true that there is a trend towards atopy, and this has also been reported by Gline et al., a published paper, then there may be a bias towards more Th2 responses, which can drive atopy. And as there is a balance between Th1 and Th2, then Th1 responses are weaker. And as you know, Th1 responses are key to develop antiviral responses. So there may be an intrinsic bias towards inefficient antiviral responses. That is one of the hypotheses I would like to explore. There may be genetic parameters, or maybe it was that at the time they got infected, maybe their immune response was already engaged with something else, and they could not mount a proper immune response to SARS-CoV-2 for some reasons, locally. These are all speculations.
Lots of work ahead of you. Thank you very much again. And please, I'm not cutting questions. I would like you to, this is why I invited you in person, use the lunch break for really talking to the experts, exchanging ideas, and generate new research questions. So it's my great pleasure to announce the next speaker, who will be Professor Resia Pretorius from South Africa, Stellenbosch University. Yeah, and she's online. She will refer on tiny blood clots and endothelial dysfunction. Thank you for joining us.
Thank you very much, Kennedy. I presume everyone can hear me. I'm just going to continue then. So hello, everyone. Today I will be sharing with you our latest research on clotting pathologies, and I will spotlight our recent findings in COVID-19 as well as long COVID. There are just some disclosures that I would like to share. I've got various funding from Polybio Research Foundation, Bellevue Research Foundation, and our South African National Research Foundation, and the Medical Research Council in South Africa, as well as the Colonel's Funding Initiative. I do also want to acknowledge my various research collaborators. This is obviously just a very shortened list, and I'm mainly focusing on my South African collaborators, and also Professor Douglas B. Kell, who's from the University of Liverpool, and we have been doing research since 2011. Various clinicians, also a team of biochemists, a team of data scientists, my PhD students, and my laboratory manager, Chantal Finter. I would also just like to note that Mediclinic Private Clinical Hospital approved sample collection at their facilities, and this is the data that I'm going to show today. And we also received ethics from both our Stellenbosch Ethics Committee as well as Mediclinic. My lab and our collaborators from various labs over the world have been identifying inflammatory molecules in circulation that might be involved in and drive pathological clotting. And we have also focused our research endeavors on studying the effects of increased circulating inflammatory molecules and how they interact with cells of the hematological system. We focus in particular on platelets and red blood cells, as well as on the clotting protein fibrinogen. We are also interested in identifying novel inflammatory molecules that might play a role in the persistent symptoms of long COVID. Over the years, we have published numerous papers that show the importance of inflammatory molecules in circulation and their role in abnormal blood clotting. I am specifically interested in platelet signaling and the role in abnormal clotting. Platelets, as you know, in circulation play a critical role in healthy blood clotting. However, they can become overstimulated and can drive pathological blood clotting if there are inflammatory molecules in circulation. This can also happen in the presence of viral infections, where platelets can act as important signaling entities. There is also a complex relationship between receptors on platelets and endothelial cells where circulating inflammatory molecules may bind to. As we now know, damaged endothelial cells and platelet hyperactivation are central pathologies also in long COVID. Our research group have therefore showed these pathologies in acute COVID and also long COVID and also conditions like ME/CFS. In the context of COVID-19, platelets are therefore central in immune activation and general coagulation pathology, and they can form various complexes and obviously also within cells. In that case, it is known as platelet clumping. We are also interested in pathological blood clotting, as I mentioned, involving the main clotting protein fibrinogen, which is a soluble protein in circulation when you are healthy. If you focus your attention to the three cartoons shown here, on the left, cartoon A is a healthy protein structure, which has many alpha coils and few beta sheets. However, in the presence of inflammation, oxidative stress, and circulating inflammatory molecules, this structure changes where the inflammatory molecules, also spike protein, may bind to the fibrinogen proteins, shown in cartoon B. Such direct protein-protein interactions may cause the alpha coils to untwist into beta sheets, as seen in C in the cartoon on the far right. We suggest that fibrinogen molecules then have a fibrinoloid structure, and we have shown this with various amyloid protein markers like theoflavin T and amitrackers. We call these fibrinoloid plasma proteins microclots. We have looked at blood clotting in acute COVID right in the beginning of the pandemic using scanning electron microscopy. We found that platelets are damaged and clump together and attach to red blood cells. The clotting proteins that is supposed to be soluble also form spontaneous microclots. In the micrographs on the far left, you can see platelets that are hyperactivated. Note the yellow arrows. In the middle are micrographs where platelets are attached to red blood cells. Note the white arrows. On the far right, you will see micrographs of spontaneously formed microclots that even glue together red blood cells. Note the blue arrows. Now, with this ultrastructural pathology in mind, we took platelet-poor plasma and exposed it to our fluorescent marker, theoflavin T, that I just talked about in the previous slide. This binds to open hydrophobic areas in protein that are damaged. This marker was first used to identify amyloid protein in brains of Alzheimer's disease patients. However, in 2016, our research group discovered that theoflavin T also binds to misfolded fibrinogen and fibrin proteins during pathological blood clotting. Here you can see the differences in platelet-poor plasma structure in acute COVID-19 patients during the acute infection, where we compare plasma smears of these patients to that of healthy participants, as well as to patients with diabetes. Here we can see microclot formation demarcated as the green signal from theoflavin T, our marker of misfolded protein. We found small areas of nearly abnormal detectable clotlets present in plasma of healthy individuals, as you would expect, and this can be seen in micrographs on the far left. More abnormal microclots were noted in plasma of individuals with diabetes. What was, however, quite significant to us was the extent of the abnormal microclots in acute COVID-19 plasma, as you can see in the far right plate. Also note the scale bar of 10 micrometers at the bottom of the micrographs. Here are examples of platelet hyperactivation during acute COVID-19. As microscopy results are difficult to quantify, we therefore suggested at that stage a microclot and platelet grading system based on various stages of severity of both microclot activation and based on the various stages of platelet activation. Here are examples of our platelet grading system. In our experiments, hematocrit samples are exposed to two fluorescent platelet markers. The one is CD62P, which is the pinkish signal, and that is a marker for P-selectin. This marker is either, the molecule is either inside the platelets or on the membrane, or it can be found as a soluble marker. Here we show where it is found on the membrane of the platelets and where it acts as an adhesion receptor. We also use PAC1, which is the green signal that identifies platelets through marking of the glycoprotein 2-beta 3-alpha, which is found only on platelet membranes. The micrograph plate on the left and the top row shows examples of platelets from healthy or control samples. There obviously minimally activated platelets are noted. This we demarcated to stage 1. The plate shows increased platelet spreading and the beginning of clumping. The micrograph plate on the right shows platelet clumping, and at the bottom, the most severe examples of these platelet clumps. Here is our microclot grading system shown on the left plate. Stages 1 and 2 demarcates minimal microclot formation that you would typically find in a healthy individual. We also suggest that the various stages can be used in a numerical scoring system that might be used in both acute COVID-19 and long COVID patients. Just for comparison, I just again added the examples of how microclots look like in type 2 diabetes. Now, with this knowledge in mind, we also looked closely at spike protein. In 2021, we looked at the effects of addition of the S1 of the spike protein on clotting when we added it to healthy blood samples. Here you can see how it also causes microclot formation in the green signal, as you can see in the slides on the left, B and D, and A and C is the original plasma, which we then expose to spike protein. And you can also, in the pinkish signal, you can see that it also activated platelets from healthy individuals. If you look at these slides, we also looked at scanning electron microscopy. And on the left, you could see red blood cells and also platelets. And you can also see how in the presence of spike protein, the S1, as I mentioned, a significant induction of these activated platelets and microclots are noted. These clotting pathologies with microclots are seen in these micrographs. And then we also thought, let's initiate a microfluidics experiment, which can be seen in the plate on the right. Healthy plasma do not have much microclots, as you would expect. However, in both acute COVID-19, which in this case was the earlier Delta variant, significant clots are seen in our fluidic system. And when we added spike protein, we could induce similar structured microclots. We are also very happy to report that the microfluidic system that was developed by Dr. Martin Crater at the Max Planck Institute also reported these similar type of microclots in their fluidic system. In fact, I'm very happy to report that his instrument was actually shipped to our lab earlier this year, and we are doing some collaborative research with Martin on the structures of the microclots in his system with our population in South Africa. Recently, also together with various collaborators from the USA, we looked at microclots and platelets from the more virulent Beta and Delta variants, and we compared it to Omicron. Here you can see, as one would expect, because Omicron is not such a severe disease, Omicron individuals in the acute phase have much less microclot formation than with the earlier Beta and Delta variants. However, if we look at platelets, we could not really see a difference between the platelet hyperactivation. Omicron seems to also cause significant platelet hyperactivation. Then obviously we know that long COVID is a massive dilemma. And we looked at blood samples from patients soon after we realized in end of 2020 already that there might be a dilemma with disease in long COVID patients. We also soon realized that there are persistent microclots and widespread endothelial damage as well as platelet hyperactivation in these individuals too. And we believe that these pathologies may be central in causing the widespread symptoms in these patients. And it may eventually lead to conditions like tissue hypoxia that may result in many of the, or might be a causative reason for many of the symptoms that the patients have. Here is just how we saw some of the microclots and platelets in long COVID. As you could see, significant microclot formation as well as significant platelet hyperactivation. We also initiated a South African long COVID registry in 2021. And here you can just see some of the symptoms as well as the comorbidities. And in our South African population, we don't have results that are dissimilar to the rest of the world. We see the same trends with brain fog, concentration issues, forgetfulness, constant fatigue as some of the main complaints of our patients, and our comorbidities high on our list of people with previous comorbidities, high blood pressure, high cholesterol, rheumatoid arthritis type conditions. We also planned an experiment where we looked at proteomics of healthy plasma and type 2 diabetes, acute COVID-19 and long COVID, and our healthy and type 2 diabetes samples were stored. So we know that they did not have any possibility to have been exposed to spike protein. And we also added the diabetes samples, obviously, because we know people suffering from diabetes are more prone to severe COVID-19 symptoms. For our proteomics analysis, we prepared platelet-poor plasma from citrated blood. And as you would, it's a typical experiment, we needed to have a digestion step, which is trypsin. To our surprise, we found a visible deposit at the bottom of the Eppendorf in the acute COVID-19 and long COVID samples, but not in the diabetes samples and also not in our healthy samples. Plasma proteins, therefore, were fully digested in controls in diabetes, and this suggested that trypsin could degrade all of those proteins, but not the proteins that are present in the COVID and long COVID samples. For our proteomics, we then developed a second trypsin digestion protocol, and then we could fortunately solubilize the digest the pellets. We then looked at the various proteins after the second trypsin digestion step, where we could digest all of our microclots, and we detected various inflammatory molecules that were substantially increased inside the now digested microclots of patients with acute COVID as well as long COVID, versus the equivalent volume of fully digested fluid of the controls in diabetes samples. Obviously, some of the molecules that we would expect and that we obviously found were some of the fibrinogen molecules that we would expect there, von Willebrand factor. But of particular interest was a substantial increase of alpha-2 antiplasmin. And that gave us quite an interesting phenomenon if we look at the clotting cascade. So as I mentioned, alpha-2 antiplasmin was significantly increased, and the reason why it's so interesting for us is the fact that alpha-2 antiplasmin is a molecule that prevents clot breakdown, and it interferes with the fibrinolytic process. And that might give us some information on why the actual little microclots that we see in circulation of these individuals simply do not break down. What our information also gave us, our proteomics analysis also gave us, is an idea that many of the molecules that's typically in soluble form and that ELISA protocols or experiments were supposed to pick up will probably not be picked up because they're not in soluble form. They are actually entrapped inside the microclots. We also completed a larger proteomic study, and all our results were confirmed. However, we were also in this second publication that we published last year, surprised to find a significant presence of antibodies entrapped inside the microclots, which gives us quite nice information about the possibility of a significant immune activation. Our findings, however, mainly from this proteomics analysis, suggest that hypercoagulation and vascular damage are key role players causing the various symptoms. Following from this research, we also revisited our stored sample, and we looked at the inflammatory molecules in the soluble fraction of the blood to see if there's possibly a way to use some of these molecules. We looked at von Willebrand factor, platelet factor 4, serum amyloid A, as well as alpha-2 antiplasmin, and we also looked at E-selectin and PCAM. And those two are obviously endothelial markers. Here you can see just some of our results from the study where these molecules are significantly increased in alpha-2 antiplasmin, obviously our main interesting molecule that was significantly increased in the soluble fraction as well. We also looked at ME/CFS because we know it's related to long COVID as a post-viral disease. To our surprise, or perhaps not surprise, I think we thought we would be getting these results, but we also found microclots in platelet-poor plasma from ME/CFS patients and significant platelet hyperactivation. What was, however, interesting for us is the fact that ME/CFS microclots are not so large in size as we found in long COVID and acute COVID. But that is not surprising because we think that the reason for the large clots is basically the presence of spike protein as well. We also found a significant number of endothelial debris in our platelet-poor plasma in both ME/CFS and long COVID. And this is unpublished research where we added E-selectin as our marker. And here you could see that there are these endothelial debris present and floating around in the platelet-poor plasma. And here you could see our control. Looks obviously we don't expect to have endothelial damage in controls. Long COVID, we do have lots of these debris lying around. And we found this one big piece of endothelial damage mark with E-selectin in our ME/CFS samples. Lots more, but this is just one of the nice pictures that I would like to share with you. Then the question arises, we have now looked at these samples, platelet-poor plasma and platelets, using microscopy, but is there a place for flow cytometry? And recently, with the help of various funders, we acquired an imaging flow cytometer. And here you could see some of our very preliminary results where we indeed found these microclots, and we can now, with this methodology, with the imaging flow cytometer, count the clots and work out the area ranges of the sizes within controls and various patient groups. And this is just some of our latest research. This paper is in preprint. We also looked at clinician-initiated treatment regimes, and this is some of our platelet data. In this case, we looked at 91 patients from our clinical collaborator who treated long COVID patients that he identified as having clotting pathology with anticoagulant regimes. So just a disclaimer, I'm not a clinician, so I can't go much into what he used and why he used it, but it's a triple anticoagulation therapy. And these patients, 80% of them, and it was obviously just a snapshot, reported that most of the most prevailing symptoms were much better after treatment. And here you could just see the patients filled in a PGIC scoring where they themselves report whether they feel better or not. And the average of 80% was reached where 80% of the individuals that we followed said that they felt better. Interesting for us, if the patient said that they felt better and the symptoms was not so severe, their microclots as well as their platelets were significantly reduced. The microclot formation and platelets were not as hyperactivated. So this gave us quite a nice result where we looked at the PGIC score before and after treatment, and when patients say they felt better, they actually indeed looked better as well under the microscope. So here's just overview of what our thoughts are. So just to bring together some of the major elements of what we have seen. So we believe that, as we all do, long COVID is an extremely complex disease where ischemia, hyperperfusion injury might be driven by platelet hyperactivation, fibrin microclots, circulating inflammatory molecules, as well as antibodies and autoantibodies. And ultimately, these pathologies suggest that long COVID might be, in fact, a thrombotic endothelitis that we should focus on and try to treat, as well as looking at viral persistence and all of the other immune-related issues that these patients might have. I wish to also turn your attention to the February 2022 US government document, the GAO, where microclot presence, viral persistence, autoantibodies, together with organ damage, were recognized as central pathologies to look into in finding answers to long COVID. At the US National Academies of Sciences meeting earlier this month, where I was also giving a presentation, the Chief Medical Officer of the FDA again referred to this document and showed this specific slide as well, suggesting that this should still be a key focus in searching for answers for long COVID. Again, microclots were noted as a central pathology to look into. I'm very happy to report that our work was also featured in Science as well as in Nature, and the beginning of the year also in National Geographic. So just to end off this presentation, I have some take-home messages from what we have found. And we believe that the relevance of receptor inflammatory marker interactions, and including in this is also autoimmune reactions, may be driving the disease pathology. And there's also a relevance of direct protein interactions in clotting pathologies in long COVID. And perhaps there's a place for novel methods in the diagnosing of well-known as well as new diseases like long COVID. And here I would like to include the use of fluorescence microscopy, perhaps an automated system, proteomics, which might not be a point of care, obviously, as we know it's difficult to do, but it might give us some more information. And then definitely a place for imaging and typical normal flow cytometry. And then there might even be a place for novel point of care technologies to study the flow and the clotting propensity in individuals with these type of diseases. Thank you very much. And thank you very much again for asking me to present our results at your wonderful meeting.
Well, thank you very much for this outstanding talk on platelets and the consequences. Are there questions? Yes, please.
Thank you very much for this very interesting presentation. So my question is if these changes are really COVID specific, or we can translate maybe this knowledge also to other infection diseases. Thank you very much.
Thank you very much for this question. I totally agree with you. This got a lot of. Sorry, I'm hearing feedback. So just, are you hearing feedback as well? Is it okay now? Okay, so I think it's a very valid question that you're asking here. I think clotting pathologies and platelet hyperactivation and microclot formation is not only a phenomenon that is true to long COVID. What was so striking for me was the size and the sheer volume of the microclots, and that might be related to the spike protein. And then platelet hyperactivation as well. I've never seen the amount of platelet hyperactivation in any other disease. As I mentioned with ME/CFS, we've noted microclot formation there as well as platelet hyperactivation. But those patients were collected, samples were collected, we know they did not have COVID. So we do see microclot formation in these conditions as well. Interestingly, previously, long before COVID, we actually looked at LPSs and LTAs from bacteria, and we could actually induce microclot formation and platelet hyperactivation using bacterial inflammagens. So I think it is perhaps at this stage, and perhaps COVID opened up the scenario for us to further look at how clotting pathologies might look like in various infectious diseases. And it might give us an idea if there's EBV or any other of the virus bacteria that is known to be involved in conditions like ME/CFS. That might give us a place to search for treatments if we have widespread clotting and platelet pathology, which will eventually result in a thrombotic endothelitis in these individuals too.
Can I ask another question? It's actually well known that viruses can host in platelets and reproduce themselves in this. Is this known for COVID?
We were actually just having a discussion last night with a few of our collaborators in the US from Harvard and from Yale and in our meetings. And we have also thought that this might be a very important avenue to look into. I myself have not found, I have not looked whether platelets might harbor the virus or spike protein inside them, but it's probably a really good research question. And I think there are some of the researchers in our wider community of long COVID that are planning to look into this. Also, perhaps in looking into the megakaryocytes, what's happening with viral spike protein, virus itself, inside the megakaryocytes and perhaps inside the bone marrow. So I haven't looked, but I think it's really a good idea to look.
Well, if there are no further questions, thank you very much again. Have a good day in South Africa.
Thank you.
And
Thank you.
It's my pleasure to announce the last speaker for this morning session, and this will be Professor Ertl, who is coming from the German Center for Cardiac Insufficiency from the University of Würzburg, and he will speak about the sad heart after COVID.
Dr. Wollenberg, ladies and gentlemen. Yeah, thank you, Dr. Wollenberg, again, and ladies and gentlemen, we'll be talking about cardiovascular diseases in COVID and their relation to psychology and especially in depression. Cardiovascular diseases lead the statistics of hospital admissions and are the most frequent causes of death, at least in the Western world. If they result in heart failure, prognosis and quality of life deteriorate rapidly. Psychiatric disease versus comorbid depression in heart failure are different entities, and I'll show you some proof of that. If you look at the left-hand side, you see in the graph all-cause death and more or less a dose-response relationship to the severity of depression with a very steep fall of the survival curve in patients with most severe depression on the bottom. On the right-hand side, you see vice versa, the severity of heart failure on the x-axis, and the prevalence of depression in these patients, which is very high, both any depression or major depression. If you look at stage 4 heart failure, these are patients who do have symptoms already at rest. So you see there's a vice versa relationship between the conditions, and both conditions are very frequent, even in a normal population without COVID. What is important, therapy is different between depression, patients with comorbid depression with heart failure or cardiac diseases or other diseases, and heart failure and otherwise healthy patients with depression. You know that antidepressants are used widely in patients with depression, but in organic disease, we have studied that in heart failure in the MOOD-HF randomized clinical trial published 8 years ago in JAMA, and we compared escitalopram with placebo in a randomized controlled and double-blind study. The result was what concerns the primary endpoint, that was time to all-cause death or hospitalization, was completely negative. Though our hypothesis that depression was the factor which killed patients with heart failure was in a way falsified. More than that, and that has been shown also in the SAD heart trial, and therefore the name of my talk, we didn't find any effect of the antidepressant over placebo in these patients with depression on the basis of heart failure. So obviously, there is a difference between depression in otherwise healthy patients and those with heart disease. Now, in patients with so now this is a subgroup analysis of this study in which we even show an adverse signal in patients with more severe heart failure. You see here, those with more severe heart failure have even worse prognosis. Also, it was not significant. And patients with a higher signal for NT-proBNP, which is an indicator of the severity of heart failure, show an even higher rate of death and hospitalization, that's the primary endpoint, than in placebo. So this again demonstrates how important it is to differentiate these two types of depression. Now, getting into COVID, psychological disorders are major components of long COVID, and we have discussed that today. And you asked the question, what is psychology and what is organic in the post-COVID syndrome? So it's very difficult to disentangle these two entities. If you look at the incidence or prevalence of depression, you see it's relatively high in post-COVID patients, both at 3 to 6 months as well as later on long term. That's more than 6 months after infection. There are other problems, of course, like cognitive dysfunction. So what about inflammation as a risk factor for both depression and heart failure? Well, in heart failure, in chronic heart failure, inflammation has been shown, and it has also been shown that inflammation has prognostic impact in patients with heart failure. And in depression, we also see that inflammation is probably etiologic factor even for depression. Maybe that it will be discussed this afternoon more. So what does COVID do in patients with heart failure, or does it in fact induce heart failure? What does it do to depression by inflammation, by autonomic and endothelial dysfunction, but also, and that's very difficult and complicated, by social psychological factors which are so dominant in this disease. So we know that heart failure is related to prognosis and progression with depression, and both may be related to each other by inflammation and these other factors. Another interesting mechanism which is considered and is very interesting for cardiologists is the angiotensin-converting enzyme receptor, which is responsible for the transport of the virus into the cell. And most of you will know that in heart failure, ACE inhibitors are very important drugs. So this is studied now widely, but we have no answer yet. But the ACE receptor is an interesting field of research. So in heart failure, we do have certain circulating biomarkers which indicate prognosis, like BNP is one important one, and troponin T and I, which are used in diagnostics of cardiac ischemia, for instance. And I can't go through all these biomarkers, but some of them are important if we discuss COVID-induced chronic cardiac disease, post-COVID cardiovascular disease, and that's for daily life, it's more or less CRP, troponin, and BNP. One major problem also is that symptoms in cardiovascular diseases are rather unspecific and similar to that what you see in depression. Let's go through the meta-analysis of the prevalence of cardiac-related symptoms in long COVID patients. And you see many patients with chest pain, palpitations, dyspnea, which is of course also lung disease indicator, cough, exercise-induced dyspnea and ventilatory inefficiency, probably a rather important dysautonomia, and post-tachycardia syndrome, orthostatic intolerance, and so on, all with the autonomic system associated. So you see, if you ask through any general population, patients, somatic or psychosomatic, they will report more or less these symptoms. So what is important and hasn't discussed so much today is that the prevalence of cardiovascular disease, but also of other post-COVID symptomatics, depends on the severity of acute COVID-19. This is a huge study. It's very interesting how fast worldwide huge numbers of patients were collected into such studies, except in Germany. In Germany, it took a while. Now we have some, but we have heard it today already. Data protection prohibits it. So we are just now really working on it today with the data protection institutes and institutions in Germany to get these type of studies done. Another study was done by Oxford. They did in 3 months, more or less, a 5-arm study and clarified treatments in COVID. So impossible in Germany. And they combined, and that's the clue, data from the healthcare system with controlled studies. So that's really interesting. It's interesting to have epidemiology from healthcare systems, but we have learned that we need the controlled trials. So if we can combine these two, then we really get a step forward. So these are millions of patients, almost 20 million of patients screened in this study, and at the end they were compared COVID patients with patients from contemporary control and historical control. And these are the results what the cardiovascular events concern, and you see the correlation between non-hospitalized, that are the green barrows, and hospitalized, the brown, and ICU patients, the blue or purple. And you see dysrhythmias is frequent, and if you look at any cardiovascular outcome in the patients who had been on ICU, then you really have a high, relative high number that is about 30%. It's the per mil in the label, but it's almost 30% that these patients have any type of cardiovascular outcome. So what are the manifestations of cardiovascular disease? You see it's mostly in the arrhythmias atrial fibrillation and sinus tachycardia. So arrhythmias are important, and heart failure. These are, of course, all patients in this graph. That means these are dominated by the patients who were in the acute phase on the ICU. So what is the role of inflammation, of cardiac inflammation in this disease? This is a patient, a 57-year-old woman, 201 days after COVID-19 infection, and the MRI of this patient with late gadolinium-based contrast enhancement, and you probably really cannot see it, but the red arrows show white spots in the myocardium, but they also show in the pericardium late gadolinium enhancement. That means inflammation in this patient. And also it shows the dark here, that's the blue arrow, that's pericardial effusion. So that's a classical perimyocarditis in this post-COVID patient. But as I've shown before, inflammatory heart disease is very rare. So if we look at very COVID-specific diseases in these patients, then they are extremely rare. So if we have a combination of cardiovascular disease and COVID in the acute situation, it's very high, it shows a very high mortality. This is in patients with acute heart failure who present at the intensive care unit with COVID-19. And you see in comparison the patients without COVID-19 and the patients with COVID-19, matched groups, and the mortality is very high in the patients with COVID-19. Another problem for the cardiologist is the downward spiral of deconditioning. Patients get immobilized, and that's particularly harmful for patients with cardiovascular disease, especially in heart failure. This downward spiral goes very fast, and you put a patient in hospital or in the intensive care unit, and he's deconditioned, and he may get never back to his former condition. So this shows a little how that happens. There are early symptoms like fatigue, but diminished activity or even bed rest, and cardiovascular deconditioning results in cardiac atrophy, and decreased circulatory conditions. That worsens the symptoms and goes into more fatigue, more decreased exercise capacity, and so on. So in daily life, we have to really take care of this. One word, since that has been discussed widely in the society, is the post-vaccination myocarditis. It happens. It exists, and it's probably due to vaccination. It can also be accident, since it's so few patients. 39 to 47 more cases of myocarditis in a million of male individuals, versus all the benefits of vaccination. So definitely, if we discuss that, it's clearly on the side of vaccination. So what have we to do as cardiologists in daily life with our patients with long COVID and associated cardiovascular disease? Indeed, we measure troponin in all COVID patients with cardiovascular symptoms. That's reasonable. inflammatory coagulation and organ disease parameters, ECG and chest X-ray, should be done in all long COVID patients, since we have to work up what is the organic substrate of long COVID. We perform a cardiology screening of patients with cardiovascular system during the with cardiovascular symptoms during the acute phase. If there is any angina pectoris and so forth, we have to go on diagnostically later on. And we do it in asymptomatic patients with previous heart disease. So our chronic heart failure, coronary heart disease patients get a workup 3 months after COVID infection. And we need a cardiology screening of our patients with long COVID and unclear symptoms. A major problem in daily practice are the patients in which, with long COVID in which you don't find any objective result. And cardiac MRI should be done in patients with new onset of cardiovascular disease after COVID, since it could be myocarditis, and in athletes before they go back to sports. So I come to conclusion. I have worked down with you this list of relations between heart, brain, psychological disorders, and COVID. And at the end, we have to say many aspects of long COVID are similar to other post-viral diseases, and we have discussed it before. So it's really not yet clear whether this is a general post-viral disease in our patients, whether it's a post-ICU disease, since we have all these problems also in patients who went through intensive care, which is an immense stress for these patients. And well, what we see is, and that's also a question of communication. We have discussed it just before. Worldwide, COVID has been communicated in a way that has never been done before, also with the media we have today. So the way of communication we have to, that's a scientific problem, in fact, not for doctors, but it's a scientific problem. How does the way of communication of facts or non-facts of diseases influence the prevalence of then further diseases? Yeah, well, that I have said, without any pathological tests, cardiovascular symptoms, that's really a challenge for the doctors, not really the cardiologist at the end, but for the family doctor. He has to follow up these patients and reassure them, and maybe at the end there will be a disease which we not really know yet, but we have to study it. And we have no really therapeutic options for long COVID, except symptom management. We do our regular therapy like in other heart failure patients. And as always, further research is needed. And these are the outstanding questions related to COVID, but I think we can discuss that later on, and I'll finish up here since my time is over. Thank you very much.
Well, thank you very much for this interesting talk. Are there questions?
Yeah, Georg, in terms of cardiovascular comorbidity, COVID is not so different from other infectious diseases. We know this for flu, we know this for other viruses, we have seen it in bacterial pneumonia, a very, very high increase of long-term cardiovascular morbidity and mortality, which lasts 10 years after the pneumonia event. What is the pathophysiology behind, and do you see any measure besides vaccination which could be preventive?
In fact, not really. As I stated at the end, therapeutic interventions are symptomatic more or less, or the classical therapy of heart failure and other diseases like coronary heart disease. It's also discussed whether long COVID goes along with progressive atherosclerosis as a chronic inflammatory process. That's very interesting, but for daily life, we haven't any measures yet. But there's, in fact, a wide interest on the inflammatory component in cardiovascular diseases, which is not obvious. CRP is mostly relatively low, not really inflammatory. But in experimental research, there is lots of progress now in understanding how cellular-mediated or humoral-mediated inflammation can contribute either to atherosclerosis or to plaques or to plaque rupture. And I think it's a very interesting field. Give me 10 more years and I may have an answer. Okay.
Well, thank you very much again.
Thank you.
I think we now come to the very next speaker, which will be on the problem of empty stomachs after such an interesting morning. And I would like you to invite to come with us for the lunch break and be here back at, well, I think 1:45 or 2:50 in order to continue with the afternoon. Thank you.
To the second part of our symposium, and the first speaker will be Marco Prinz. He is a neuropathologist from the University of Freiburg with special expertise in CNS autoimmunological diseases.
Good. Thanks a lot, Uta, for this nice introduction. I would like to speak about how the brain reacts upon infection, especially upon SARS-CoV-2 infection. Special things thanks to my co-worker, Mario Schwabenland, who basically also prepared some of the slides and did research together with me for the last couple of years. And just one slide for introduction, who I am. I'm a trained neuropathologist, and what we're usually doing is clinical routine diagnostics in the hospital in Freiburg, where we have every year thousands of samples diagnosing, sitting around the microscope. And usually these are brain metastases and other malignancies, brain tumors, very rarely any inflammation. This is also a major problem in the field, that there are no biopsies taken from inflammatory conditions like SARS-CoV-2. And that's why our understanding about this infection is quite limited. So you see here the neuropathologist sitting around the microscope. However, the institute is much, much bigger because many people are there for doing diagnostics, but also for doing research. And we just recently moved to a new building, the Imitate building, where we have nice space for doing research. So what is known about brain involvement in COVID, acute and long COVID infection? And the beamer is not the best one. Well, it's quite clear that there are major results, major effects in the brain. And I would like to start to make clear that we certainly have neuroinflammation. I will come to this in a second. And certainly cytokine storm. And it's clear that the brain is packed. You have many cell types. You have astrocytes, oligodendrocytes, neurons. And all these cells are somehow involved. And as a result, if you have a change of this neuronal connectivity, patients have so-called brain fog. As a result, there's impairment, cognitive dysfunction, mood changes. However, the underlying mechanisms are poorly understood, right? It's not clear basically how this comes to these different things. For clinicians, it's quite easy. Neurologists can perform cognitive investigations, and radiologists can do some PET traces, but for neuropathologist, we are quite limited in the material. However, what is also supposed one cause could be autoimmunity in the brain that can be causal for subsequent changes of the cognition. People also suspect, but it's not proven yet, that we have a neuroinvasion. We mostly think that the virus is not directly affecting and involving the brain, only indirectly. It might be that latent viruses are activated, like EBV, for example. What is quite clear is that the vasculature has changed. We have changes in the capillary network, and also disturbances in the brain homeostasis have been described. So, as I said, for the neuropathologist, it's challenging to understand what is going on. The big question in the field is how can we really monitor any changes in the brain? We have there are not good any good PET traces. There's just TSPO PET tracer, but here we cannot monitor inflammation at all. But the big challenge here again is if we have patients' material, how can we change anything? So, and what we usually do for any kind of pathology, if we have brain biopsies, if we have brain autopsies, we look for the watchdogs of the brain. And these are the very sensitive cells. And what type of cells are the watchdogs of the brain? These are the macrophages. So, and macrophages are a very specific cell type in the brain, part of the immune system, and you find macrophages everywhere in the body. In the liver, these are the Kupfer cells. In the skin, as Langhans cells. In the bone, as osteoclast. In the brain, macrophages are called microglia cells. And they are localized, basically, as I said, in a central nervous system where they have central functions. So what is important is that we need these brain cells, the brain macrophages for the normal, proper homeostasis, but we need them also for any kind of infection. So it's important to have for immune surveillance and tissue homeostasis normal equipment with tissue macrophages with microglia cells. So, and this is one movie I will activate in a second, where the macrophages, the immune system in the brain, the healthy brain is monitored. You see microglia cells as macrophages, the important macrophages in the brain. In green, you don't see the neurons, oligodendrocytes in between, but what you nicely see what they are doing. So in a healthy brain, and this happens actually if you listen to me now, and this is actually what the cells are doing, sorry. They are highly active. So exactly, highly active, you know. And it's really fascinating to see that these cells, even in healthy brain, continuously extend and retract the processes, yeah. I think it's fascinating. Your neurons in the brain are fixed. The astrocytes are more or less fixed. Only the immune cells in the brain, like these microglia cells, continuously really shapes the brain, in a healthy brain, yeah? And it's fascinating. If you close your eyes and think or try to feel that the cells inside your brain are really massaging your neurons. It's really fascinating to have such highly active cells inside the brain. So, but these cells are always active, health and disease, day and night, but they're highly sensitive. Even within minutes, these cells are activated. And they are in close vicinity to neurons. You see in the middle a microglia cell, macrophage in the brain, in close vicinity to neurons. And if these cells are activated, microglia cells, you can imagine that neurons are consequently activated, but also oligodendrocytes. Yeah? Oligodendrocytes closely interact with the immune system in the brain, in the healthy brain, and any kind of adaptation to the environment, memory, synaptic pruning. The immune cells, microglia cells, are interacting with astrocytes, neurons, all these cells. So, but if you have a disease, the disease is primarily activating this immune cell, the whole system changes. Yeah? It's clear that upon pathology, for example, inflammation, microglia cells start to become activated, and they release cytokines like IL-16 alpha. As a consequence, the cytokine storm can be involved, and this might be toxic to neurons. As a consequence, you have neuronal damage. And since these are macrophages, they are able to present MHC class II, and consequently can activate T cells. Yeah? And usually you don't have T cells inside the brain, but if microglia cells are activated, T cells can be activated and clonally expand. It's a situation you don't want to have in the brain. And this happens in many diseases of the central nervous system, like Alzheimer's, as well as in neuroinflammation. If you have a meningitis, multiple sclerosis, these cells are activated. So, and for us, it's really important to understand what is the behavior of the cells in healthy brain and diseased brain. So, and just to summarize for the cell type, a multifunctional cell type, microglia cell, close to neurons, really shaping the neuronal circuitry, but also interacting with astrocytes. They can be, on one hand side, gardener. To shape the neural networks, they can be a kind of alarm clock, watching what is going on in the environment, and they can also clean the rooms if things are not in a good shape, and if you have any kind of garbage inside the brain, this will be removed by the cells. However, if you have a activation for a long period of time, these cells get hyperactivated, and we have these cells a kind of a bad guy. They can induce a cytokine storm and subsequently damage neurons. So the big question is, how does a bad guy looks like in the brain. And what people do, they do histology under the microscope, for example, and this is a normal shape of a microglia cell. You have seen the movie, and these arms are always active. The good microglia look like this. All the processes, small, tiny cells. However, if you have a kind of pathology, inflammation, these cells get activated, retract the processes, get a foamy shape, rounded shape, and this is actually a hallmark of disease. And the big question in the field was whether we see an activation of the immune cells, of the watchdogs of the brain during COVID-19 infection, and we started with acute COVID-19 patient setting, and this was 2020, where we had the first cohort of more than 40 patients that died due to corona. This was the first big study. It was performed together with people in Hamburg and the UK, and we looked in different parts of the brain. For example, the frontal cortex, basal ganglia, pontine region, cerebellum. And what we found that especially in the brain stem, there are really changes. And we see changes in the astrocyte compartment, other important structural cells. We see some T cells, CD8 cells, but especially we saw our main innate immune cells, the myeloid cells, the microglia cells, highly activated. You see here in brown. This doesn't happen in a normal brain, but here we have a strong activation of microglia cells. And it's important that they are not alone. They're even coming together with T cells depicted here in red. And in the nodules, in the clusters where you have hundreds of cells, also T cells enter the stage. And this is a problem, that T cells get activated due to these microglia cells, and then the whole process starts. Again, this is a marker for microglia activation, CD68, another microglia marker. So the problem here is that inside the nodules, in the brains of these patients, we have activated T cells. As I said, normally you have no T cells at all in the healthy brain. And again, in histology, a big nodule, otherwise these cells are evenly distributed throughout the brain. Here you have big nodules in these patients in the brain stem, and again, inside the nodules, some T cells depicted here in red. It means these T cells get activated. And what was not clear so far, what is really the molecular signature of all the different cell types during COVID-19 infection. And we didn't use only 4 or 5 different antibodies, we used much more. And if you have more antibodies, you can really in-depth characterize the different cells. And we used here an imaging mass cytometry approach. We used up to 40 different antibodies. And if you have 40 different antibodies, you can stain subsets of T cells, subsets of myeloid cells in a given tissues. These antibodies were labeled with different metals. And as a consequence, you can really nicely, on the brain tissue of patients, analyze changes. And this is what we did. We had COVID-19 patients, different parts of the brain. We used controls, ECMO patients, but also MS patients, multiple sclerosis, that have a known pathology in terms of inflammation. Prepared slices and imaged hundreds of different images and layers to really understand what subsets of cells are and where and when are these subsets appearing. So just to give you one example, this is a normal immunohistochemistry, looks quite boring, but if we have more antibodies, we have more information and more colors. You see here, for example, we can now add CD8 and collagen to really define where inside the brain all these different foci appear. So just to give you one example, these are not 40 antibodies in total, but almost different markers here, normal microglia markers. This is an MHC class 2, standing for an activated cell, different markers to really identify and characterize in depth the different activation pattern, along with T cells. And now you can really look what is the activation state of different cells. So here, we quantified, first of all, normal myeloid cells, microglia cells. It's in a healthy brain, you have a normal number of cells, but during inflammation, here in purple, you have multiple sclerosis patient, you have an increase of cells. This is quite expected. However, in COVID-19 patients in light blue, we have an increase, but also increase of perivascular cells. It means cells around the vessels and T cells. As I told you, normally you have no T cells in the brain, but during multiple sclerosis, you have an increase of cells, and surprisingly, also in the COVID-19 patients. This was for CD8 T cells as well as for CD4 T cells, but only very few B cells. We usually see not many B cells in the brain of the infected patients, but mainly T cells. And having applied more than 40 antibodies, you have different clusters. Yeah? Here, each dot is one cell, and now you can really distinguish different activation states. So we have not only one microglia clusters, because we are now using many different antibodies. We have one microglia cluster, 1, 2, 3, 4, 5, 6, 7. Yeah? Really having the chance to analyze the different activation state. What you nicely see here is the result from the different brains, the 14 brains. During COVID inflammation inside the brain, you have an increase of this cluster 19. Cluster 19 is, for example, T cells, but as well as cluster 7 microglia cells, indicating that the number of infiltrating cells and the composition is strongly changing. So, we skip this. So, if you have a high resolution image of the central nervous system, you can also see how these cells interact each other. So, you can determine the neighborhood. What cell type is interacting with another cell type? Yeah? This helps you to define the different niches. Here, for example, for the T cells, we clearly see that T cells, there are specific T cell clusters inside the brain that are activated, yeah, and have a specific effector phenotype of the T cells. Then the major question was, at what side of the brain are these T cells activated? And here we looked in different compartments. In the perivascular compartment, around the vessels, and around the vessels we found high activation of myeloid cells here that are PD-1 positive or CD39 positive, indicating that around the vessels there is major activation of myeloid cells. Even close to the vessel, we call it juxtavascular compartment, myeloid cells are activated, as well as in the parenchyma. The parenchyma is important because you have here the neurons. That means myeloid cells are activated in human brains during pathology at different places in the perivascular space, around the vessels, as well as in the parenchyma. So, and here's a kind of summary. And here, as I told you, we have different compartments where the myeloid cell activation during COVID-19 infection takes place. Here's a vessel. Around the vessels have the macrophages depicted in brown and green T cells. Cells are activated here, and we think this is certainly a consequence or a cause of vascular damage, what we see later on. We have endothelial cell damage and finally also damage of the blood-brain barrier. And we have a strong involvement of vessels in COVID-19 brains. We find activation of microglia cells in brown with T cells, that locally activated T cells in specific compartments. And here we have in the parenchyma accumulation, so-called nodules, and interacting T cells and microglia cells. And this, we think, it's the cause of neuronal damage. Yeah? This is what we see in the patient's brains. So, then we ask, okay, is there a correlation between the damage we see in the brain and clinical parameters? And indeed, it's the case. Patients that have elevated levels of leukocytes, high inflammatory parameters, have a high damage inside the brain. We compared the different compartments in the brain, in the medulla, and compared the different inflammatory markers in the brain. And as I said, major inflammatory changes we see is in the brainstem. And as you know, the brainstem is important basically for many vital factors in patients. So we were part of another study with our neurologist that basically followed by using glucose metabolism in patients that suffered from COVID-19, their cognitive behavior and the metabolism of glucose, and could really show, together with the neurologist, that glucose metabolism is impaired during COVID-19 infection. And fortunately enough, we were able to obtain 2 brains of these patients. And again, we were looking for our immune cells for the activation of microglia cells. And this is actually what we saw. Yeah? In the subacute stage of COVID-19, especially in the frontal cortex, as well as in hippocampus cerebellum, we have a strong activation again of the brain endogenous immune cells, so-called microglia cells, that are highly activated. It means there's a correlation about cognitive impairment and glucose metabolism and underlying brain pathology. So, and there was a, concerning the long COVID, there's a recent very important study in the UK where they analyzed more than 600 brains and performed MRI and looked at the volume of the brains in long COVID patients, and they really saw a strong difference in the size of the brain, indicating over time that a kind of underlying pathology that persists in the brain over the years. So. And there are 2 more important papers, basically, that looked for the long-term cognitive impairments in patients. And one study was published in Nature Medicine last year. And what they found, and they had used more than 150,000 patients suffering from COVID and more than 5 million controls, they found an elevated risk after 1 year of disease, elevated risk of cognitive disorders, including Alzheimer's disease. And another study published in Lancet Psychiatry that even used more than 1.5 million controls as well as patients. They found, again, cognitive decline. However, psychotic disorders or symptoms like anxiety and mood were only transient. So, as I said, clear evidence from the epidemiological point of view, but it's not really proven on the long-term perspective what is going on in the brain. So, and what we and others found, basically, especially in the acute cases, we do have a neuroinflammation. That means an influx of T cells that are normally not present in the human brain. However, this is a quite subtle, mild inflammation, mostly in the brainstem, but also olfactory, but in other brain regions. We have a really strong activation of the innate immune system in the brain compared to the controls. Microglia cells express markers like CD68, MHC class II, and downregulate so-called resting factors like TIM119 and P2R12, indicating that the innate immune system, the brain's endogenous one, is activated, as well as T cells are part of the party. For example, CD8 T cells get activated, get recruited to the brain and closely interact with microglia cells. And we found that this activation of the immune system in the brain is highly compromised. That means especially in the perivascular space, as well as in the juxtavascular and parenchyma, these nodules of myeloid cells interact with T cells. We have distinct profiles. Moreover, we have clear signs, but also subtle signs, in some patients, but not all patients, of neuronal damage that are not present in the normal brain, deposition of APP as a sign of neuronal damage, and also endothelial cells. This is what we usually see and in different extent in patients. However, in chronic or long COVID, I think, at least in terms of brain pathology, there are very few, if any, data available. But we could imagine that we have a chronic latent inflammation over the years. But as I said, the evidence is not very strong so far. So, and to summarize again, what we see inside the brain of some of these patients, and as I've shown to you, we have more than 50, 60 patients now analyzed. We have a sign of neuroinflammation. And for us, it's clear that the innate immune system in the brain, microglia cells, are somehow crucial to induce inflammation, also to amplify the inflammation. They produce factors like cytokines that are harmful to some extent, induce a degeneration of some neurons. We have consequently changes in different compartments. For example, the oligodendrocytes. There are reports showing that the white matter is changed as well. We don't see it in our patients. Neurogenesis means the production of new neurons, and this patient might be reduced, as well as other cells like the astrocytes are activated. As a consequence, the brain is, as I said, densely packed. Many cells are interacting. As a consequence, we have changes of memory and behavior. And as possible mechanism, we think that autoimmune processes might take place. However, we only see very few B cells. We never saw the virus entering the brain. There are some reports about the EBV infection inside the brain. We clearly see changes in small capillaries and necrotic features of the capillary network and metabolic changes in the central nervous system. This is what the literature basically says about the possible causes of long COVID, building on what we see in the brain. We still need to have evidence that we have a long-lasting ongoing inflammation in the brain, and as I said, the images or MRI images or PET tracers are not sufficient to really justify it. Hopefully we will be able to collect more brains of patients. Degeneration of vessels are to be seen, and there are some reports that proteins like the spike protein can be detected in brains. However, and to cut a long story short, I think this is a take-home message. To understand changes inside the brain and to understand changes that are linked to long COVID in the brain, we need a deeper understanding in the future to really understand the different pathophysiological mechanism in COVID-19 brain. So that's it. Thank you very much for your attention.
Thank you, Marco. Are there questions?
Thank you very much for this very nice presentation. So my question is, so we have to define a strategy here. Actually, it's a very important goal of our community to develop strategies.
Yeah.
And actually your message would be we should put the energy and money and effort in understanding long COVID. This is a main goal. Or maybe it's more than this. The main goal is for sure to understand the mechanism of COVID, but also to put more money and energy in understanding generally the impact of viruses on inflammation and immune system, because this is really a very interesting story with an impact. I'm an oncologist, so if I could mention the HPV virus, the cytomegalic virus in brain tumors and so on. So I think this is an interesting story for a lot of areas of medicine.
Yeah, definitely. Now, I think what we certainly need is also a better PET tracer to really monitor what is going on inside the brain. Yeah? Microglia or myeloid-specific PET tracers to really monitor in patients how diseases are going on. And certainly what we also need more autopsies at the end of the day. So I remember 10 years back we had 10 times more autopsies, and we were able to have more brains to be looked at. Yeah? And this is also not the case anymore.
So thank you for the broad overview of all the possible mechanisms. I was wondering about the type of endothelial damage that you saw in the autopsy in the brains. Were there, because at some points there were mentions of phantom vessels. Did you see these? Did you see the microclotting?
Yeah, exactly. It's a good question. You know, what we clearly see in some patients are ischemic changes, hypoxic ischemic changes. But if you look closer to the endothelial cells, the CD34 positive endothelial cells, we didn't really see apoptotic cells, yeah? Neither in caspase-3 positive or having apoptotic bodies. We didn't see it, but there are some reports from other people and many people that saw it. Yeah? We couldn't really prove it, but since there are several reports, I think it's most likely true. Uh-huh.
I think I can do it like that. How was that movie?
No, they don't understand you on the web.
Thank you. How was that movie that you showed in the beginning of the microglia? Which method did you use to take it?
Did you like it?
Sorry?
Did you like it?
I liked it, but I'm curious about the method that you took.
Well, there are different possibilities. You can do it in mice, open the skull.
Yeah, how
easy.
did? But what did you use? Which technology did you use?
This was a movie from mouse, open skull, where the microglia cells were genetically labeled by GFP. But you can do the same in patients.
Yes, but what was the technology?
Two-photon microscopy.
Sorry?
Two-photon microscopy.
Two-photon microscopy,
yeah,
I see.
living two-photon microscopy.
Thank you, that was my question.
Exactly.
Thank you. Two-photon microscopy, yes, thank you.
But it's super fascinating to see the cells moving and acting. And Gerd, yeah, it's you.
Thank you, Marco. That was an outstanding talk. I have one question for the neurodegenerative part, which you just touched upon. This paper that you cited that shows an increase in Alzheimer must reflect a conversion or some sort, because the disease itself must have been present already before the COVID struck.
Yes.
So is there any evidence from your data or from other people's data that would really show an interaction between the pathological process underlying Alzheimer, whatever, or is this just the tipping point that is?
This is a good question, you know. What we didn't, I didn't show the data. In the few dozen samples we have from the different patients, these are not 100 or 1,000 patients, yeah. We did staining for Bilchowski, for amyloid, for tau, really, to see whether amyloid is there, yeah, compared to the normal controls, yeah. But as you can imagine, elderly patients, 60s, 70s, they do have, some of them do have plaques, yeah, and the controls as well, you know. And it's not clear, basically, right? And this study you mentioned, the Nature Medicine paper, did a correlation, yeah, and maybe it's just the small things that is changing the conditions. Could be, yeah.
Okay. I have one last question. Do you have an idea why the brainstem is especially affected?
No, we don't know, but it's basically not clear. And some, not in all patients, the brainstem is affected, and some olfactory bulb more involved, but why the brainstem is not clear, basically.
Okay, yeah, thank you, Marco. We go on with the talk of Tobias Welte. He is a pulmonologist from the Hannover Medical School, and he will give us the insights for the lung.
Yeah, hello, and thank you very much for the invitation. So I'm the head of the Department of Respiratory Medicine, Infectious Disease at Hannover School of Medicine. And to be honest, the last 3 years I did COVID only. I was responsible for the COVID policy for the Federal Republic of Lower Saxony. I was in the advisory board of English Public Health, of the Austrian government, of the Greek government, and so that made my day. And now I'm responsible for the Lower Saxony COVID, long COVID program. And I always say this, the government of Lower Saxony spends 15 million euros to set up a long COVID program. And the opening ceremony will be on the 5th of October in Hanover to present all the projects which had been funded. You heard yesterday Mr. Lauterbach, so some weeks ago he said we need 100 million for long COVID research. Yesterday it was down to 41, and to be honest, I'm not sure where we will end up, having in mind the pressure which is on the budget of the German government. However, I will show you that there is a big need of research in this field, and this combines basic research, I will come to this later on, but also research in terms of healthcare structures. And one of the main issues and the main learning points out of the long COVID debate, and I will say this in the beginning, is that our healthcare system here in Germany is not structured to cover it. This is an intersectoral task, starting with general practitioners and ending with specialists on a university level. And the structures to collaborate and the structure to get this financed are not established in Germany. So this is a major task for the future. So with this, I will leave the political issues. And again, my first scientific slide also is a political slide. If you look to long COVID, or I like to talk only about post-COVID, so those who have symptoms 3 months after virological cure of the disease, because we know from all data that the long COVID ones, symptoms 4 weeks after virological cure, 2 of 3 lose the symptoms in between the next 2 months. So we should focus on those who are more long-term ill to get better insights into the disease. So altogether, we distinguish between 3 main groups of post-COVID patients. And first, and you have heard about it in the morning a lot, the group which had been in the hospital for a long time, the more severely, the very severely ill patients, which had been on the ICU, and most of them had been ventilated. This is the typical group out of the pre-Omicron era. Because, to give you some numbers, from the classical variant, the Alpha, the Delta patients, about 8% had been hospitalized in Germany, 6 to 8%. From these 6 to 8%, about a fourth ended up in intermediate care, intensive care, and from those, 25% died. So this was the pre-Omicron era figure. With Omicron, and I will come back to this later on, it's totally different. So this is a very special group. The second very special group, and this is a group which is also present in the media, is the MECFS, the chronic fatigue syndrome group. You heard about it from Carmen Scheibenbogen yesterday, and you will hear about this in the talk of Uta Behrends. But to be honest, this is a very small group. From all post-COVID patients, this is about 1 to 2%. Taking the numbers of COVID-19 disease patients, it's still a remarkable number. And I will want not to put this into a basket. It's important, and it needs research, and it needs treatment, which is not present at the moment. But nevertheless, it's a minority. The third group is the most difficult ones. These are those who had been not severely ill, had been treated as outpatients, and then are symptomatic weeks and months later. And to use an American idiom, this is a melting pot, because it's not a heterogeneous kind of disease, very, very different disease entities which are present in this middle group. The CFS group is a group of patients which are not able to cover daily life anymore. The second group, this biggest group, is a group which have some impairment in daily life, but is much, much less affected in daily life. And I also will come back to this later on. Let's start with the patients who had been long time in hospital and on the ICU. And these are unpublished data from my group. We in Hanover altogether, we took care for about 2,500 long COVID patients during the last 2 years. Isabel Pink is the responsible senior researcher in my group who did it. And what you can see here is, if you look to the hospitalized ICU patients, they had been older, they had been more comorbid, and in follow-up, dyspnoe is the leading syndrome of this patient group. If you look to the other ones, the CFS, but also this big middle group, fatigue is the leading syndrome, and dyspnoe occurs in various manner, sometimes more, sometimes less, but it's very seldom the leading symptom. And this, with regard to dyspnoe, is reflected by looking to the lung function test. The patients coming from ICU show an impairment in vital capacity, something which we call a restrictive lung function pattern, and a strong impairment in diffusion capacity, whereas the other groups do not show these abnormalities in any way. And this has been shown by a lot of other groups in the same way. This was the first paper published by Wuhan people. I know Bin Chao, the head of the Wuhan healthcare system, very, very good, because we were neighbors in Brigham's and Women's in Boston for 3 years and had a lot of collaborations in the past, so I have very good insights what happened in Wuhan. And he showed the same. Diffusion capacity is the main lung function parameter which is impaired, and it's more impaired in those who had been more severely ill in the past. And a very recently published paper, January this year, confirmed this. There is a strong association between the length of hospital stay and the need for oxygen supplementation and mechanical ventilation with an impairment in lung function parameters. And if you look to 6-minute walk test, this is a classically used, easy to perform exercise test in daily practice of a pneumologist. There is a loss of 6-minute walk distance, impressive, severe loss in those patients who lost diffusion capacity. If you look to CT scans, and Hans-Ulrich Kautscher is among us here in the auditorium, and he's much better in this than I am. What you can see is, if you look to the patients on the intensive care unit, the main feature of COVID-19 is consolidation. It's a very special form of consolidation. It's very close to the pleura, so peripheral consolidations, and the central part of the lung very often is excluded. But if you look to those who are outpatients, who did not use oxygen, who did not get mechanical ventilation, it's a totally different pattern. It's ground glass pattern. And if you look to the follow-up CT scans, there are fibrotic or bronchiectasis residua in those who had been ventilated, and this is not the case in the other cases I talked about. Well, this is something which is known for a long time and cured before COVID-19. Patients long-term ventilated show pathological repair of the lung. And mainly, the lung is a complicated organ, but repair mechanisms are very simple. It's emphysema, loss of lung structure, or it's fibrosis, increase of pathological lung structure. These are the both repair mechanisms. And in long-term ventilated patients, a given percentage of patients moves forward, proceeds to fibrotic changes. And this is independent from the etiology why you are ventilated. It's a consequence of the long-term ventilation, which is in a kind artificial. And this is what we know about the pathology. There is a differentiation of macrocytes, and macrophages and macrocytes, and these lung macrophages differentiate to so-called M2 cells, and these M2 cells are stimulators of fibroblasts and induce the fibrosis process. The second group I talked about, and Uta will say more, is the CFS group. And the CFS group, there is a very long-term accepted definition of what chronic fatigue syndrome is. It has been published after a consensus conference in Canada now 12 years ago, and it had not been changed. And the definition of what chronic fatigue syndrome is well defined in this consensus paper. We should use it in long COVID also. And if you look to the difference between ME/CFS patients and others, there are a number of differences, and the most important one is that ME/CFS patients are mainly women. It's absolutely female-dominated. In my outpatient department, 90% are women, and this leads to the hypothesis that also hormones, gender-specific hormones, play a role in this process. This is something which we address in one of the research projects in the Lower Saxony initiative together with the Tierärztliche Hochschule in Hanover. Why? Because they have a very good SarsCoV2 hamster model we use in this circumstance. Well, what is totally unclear, and you heard it in the talks before, and you heard a huge number of hypotheses, what could be the reason for this post-COVID syndrome is the real etiology. And in my mind, there are several different possibilities. Direct tissue damage. In the post-intensive care patients, this may play a role because the virus and the viral induced damage is here accelerated by mechanical ventilation. We know that stretch to cells in different compartments of the lung induces fibroblast activation. and this may enhance the mechanism. You heard about autoimmunity. The problem with autoimmunity is we do not know whether it's virus-induced autoimmunity itself or whether the virus enhances an autoimmune phenomenon which had been present before. In the pneumology department, we see a lot of these autoimmunity syndromes. And what is very obvious and was very surprising, one of the diseases which increased in numbers by far was C-ANCA positive microscopic uveitis, what we've called Wegener before. And what is very special is, so C-ANCA positive disease in other patients include the kidney, the lung, the peripheral nerves, but this is a C-ANCA positive disease which is isolated present in the lung. The kidney is not present, and there's no nervous system involvement. Nevertheless, if this is the case, what we do as treatment in those cases, cyclophosphamide, and if this fails, anti-CD20, rituximab as a treatment option. This works in these patients also. Is there any sign and signal of viral persistence? This is a big, big debate, and you heard it in one of the talks. This could be an indication to use antiviral treatment also in long COVID patients. But to be honest, there's no confirmation that there's viral persistence anywhere, and mainly for the lung, it's quite clear that there's no persistence. One of the major problems in making a correct diagnosis in terms of long post-COVID and to answer the question whether it's a COVID-induced or only a COVID-accelerated, enhanced disease is these are mainly young patients. And for those young patients, you do not have lung function testing from before the COVID disease area. You do not have a CT scan in history. So it could be that there had been a clinically inapparent autoimmune disease, a clinically inapparent fibrotic disease, but it was not diagnosed. It's well known, and one of my experimental groups did a lot of murine model papers. Viruses are a trigger of exacerbation of fibrotic disease by a lot of different mechanisms which end up with macrophage differentiation and fibroblast activity induction. And this could be the same with COVID in patients who had very, very low intensive fibrotic disease before COVID came. That's, from a scientific point of view, very interesting. For the patients, it does not matter. Well, if you look to persistent post-COVID interstitial lung disease, a number of studies have been published. But I want to point out that more or less all studies are out of the pre-Omicron era. These are all studies including Wuhan, Alpha, Delta variant, but not Omicron. And mainly for patients coming from the intensive care unit, for patients needing oxygen supplementation. This is not easy to sample Omicron patients because there are very few which need intensive care management in comparison to what happened in the pre-Omicron era. This is one of the studies, as you can see, if you look to intensive care, it's absolutely male-dominated. Same for the mortality pattern in COVID-19, 2.5-fold higher risk for male to die than for female. It's obesity-driven, it's comorbidity-driven, and it's more prominent in those who are mechanically ventilated. And when you look to the follow-up, it's the same I told you. It's impairment in vital capacity, impairment in diffusion capacity, and in 6-minute walk distance. There is a huge UK cohort, a big observational study run by the London hospitals and funded by MRC. And again, I want to switch to politics. It's much, much more easy to set up these kind of studies and these registries, for example, in the UK or in the Scandinavian countries than it is in Germany. We block ourselves day for day. And if you look to clinical studies in COVID-19, none of the big studies had been done in Germany. All had been done in the UK, in the US, in France, but not in Germany. And this is because we are totally over-regulated. That's one reason. And the second reason is, well, there may be a need for federal republics and for decentralization, but pandemias are a very, very bad example for decentral management. This need central management, central guidance, and this is really difficult to bring this into German habits. Well, the paper of the UK group had been published in the Blue Journal days ago, and what they showed is the same I showed you from our data. If you look to residual lung abnormalities in patients who had been hospitalized, it's mainly fibrotic patterns, and you can measure it in lung function. So what we do in daily practice is, if a patient has dyspnea as a leading syndrome, there is a lung function test. If this is pathological, mainly if the diffusion capacity is impaired, by far, we run a CT scan, and if there's interstitial lung disease in the CT scan, the classical diagnostic approach, which is in the guidelines for interstitial lung disease, takes place. And then treatment is related to the guidelines and related to the proper diagnosis of the interstitial lung disease. I say this because if you, in those patients, make biopsies and look to histology and cytology of these biopsies, you find very different diseases. So it's from organizing pneumonia to a kind of, looks like eosinophilic alveolitis, to autoimmune disease, to something else, and everything needs different treatment and different approaches. Coming back to Omicron. Omicron is not a sister of the classical variant. It's a very far away relative. It's more transmissible because it affects the upper airways, the airway epithelial cells, much better than the classical variant, but it does not induce COVID-19 pneumonia. That's a very rare event. And we know the reason. The reason is Omicron lost the capacity to invade alveolar type 2 cells. And this is the key cell for the invasion of a virus, of a microorganism into the lung. And this does only happen in very special patient populations. And these are mainly immunosuppressed patients, transplant, autoimmune disease, if it affects the B-cell compartment, malignoma, hematological malignoma, but also only if the B-cell compartment is affected. So the B-cell lymphoma, the lymphatic leukemias, there's no increased risk for myelotic leukemia, no risk for T-cell lymphomas, no risk for patients who are stem cell transplanted. So the reason for stem cell transplantation mainly is myelotic leukemia, and these are patients without risk. There is a risk also for the elderly. Well, this is to distinguish from the others, because the elderly also do not get COVID pneumonia. But if you are an elderly person with a multi-organ failure, a lot of comorbidities, your life is just compensated. And if there is one trigger, and this could be an infection, this could be a fracture after you drop down, then you come to decompensation. And this increases morbidity and mortality. And so, yes, COVID is a trigger, but it's not a directly COVID-related deterioration of the healthcare status. That's something else. And I want to point out it, and it had been mentioned in the morning talks, vaccination protects. So no question about, if you are vaccinated, the course of COVID disease is less severe, and the amount of long post-COVID cases are less than in the non-vaccinated group. So vaccination had been key to overcome COVID disease, and I'm very disappointed that this is not more discussed in the media and is also, let me say, downgraded by the communication in the media, which is, in my mind, a big mistake. To conclude, there are a lot of open questions. One of the questions I am very interested in is the muscle pump. What we see in long COVID is not a structural change in the lung compartment, but a loss of muscle pump activity. And the reason may be some out of the neurological field, a defect in the neuromuscular communication at the muscle side. This is not very well understood and not very well studied, and I think this is something worth of further research. What we need in the future, and I said it in the beginning, is long-term research programs. I'm happy to chair the Lower Saxony Long COVID program, but it's a 2-year program. It's very naive to think that we will come to better insights and to better knowledge with short-term programs. And it's the same with the program announced yesterday by the Minister of Health. We need long-term research. And on the other hand side, we need to change our structures for these kind of diseases. Well, to finalize my talk, all of this costs money. That's how it is. And there is no cost-sparing possibility to develop new therapies, to get better insights into a disease, and to get a better care. This costs money. And this has to be said because there is a willingness of the politics to do this could be done in between the financing of the system currently available, and my answer is this will not be possible. Thank you very much for your attention.
Thank you. Are there questions? I mean, I would have one question for the patients with dyspnea and normal lung diagnostics. Do you have any hints from autopsies what it could be?
No, we do not have insights from autopsies because these patients do not die. Okay. So if they do not die, we have no insights into the tissue. We have CT series of these patients, and this is totally normal. And what we do in a research project in the Lower Saxony program now, we use artificial intelligence to analyze the breathing pattern and to have a better insight whether the breathing pattern, the muscle pump, is influenced. And when this is the case, we have to make up our minds. That's not easy, how we get biopsies out of these systems, the diaphragm, the diaphragm mainly, but this is a hard to reach environment. You see nothing.
Good. Yeah.
Thank you.
Thank you very much. And we then come to the last talk of this symposium. And as you know, also children and adolescents can be affected by COVID. And Uta Behrends, yeah, she's here, will tell us her insights in the pediatric cases.
Yeah, hello. Dear ladies and gentlemen, dear colleagues, dear patients and parents. Led by our research on Epstein-Barr virus a couple of years ago, we stepped into the worrying deficit in research and care regarding post-infectious syndromes and myalgic encephalomyelitis, chronic fatigue syndrome, ME/CFS. With the wonderful support by dedicated foundations, we were able to establish a chronic fatigue center for young people in Munich, the MCFC, so to say, the little sister of the Charité Fatigue Center in Berlin, led by Carmen Scheibenbogen. The MCFC is focusing on severely affected children, adolescents, and very young adults, including kids with post-COVID. I have no relevant conflict of interest. As you all know, long COVID was first reported by patients, including parents of affected. Something happened with my. I'm sorry. With my yes. The COVID pandemic's burden on children and adolescents all over is immense. Fortunately, the morbidity and mortality of COVID-19 itself is low, and cases with multi-system inflammatory syndrome in children are rare. However, accumulating evidence indicates that some kids get long post-COVID, and in addition, we are facing significant mental health issues, education deficits, reduced economic well-being, and increased violence to kids at home or using social media. So post-COVID is thus only one aspect of this very sad and very challenging scenario. As you all know, long COVID was first reported by patients, including parents of affected children. However, parents encountered a medical gaslighting or a trivialization of their concerns and called for belief and compassionate support. Meanwhile, very active parent advocacy groups have been established internationally and in Germany, and listening to them is most helpful. At the beginning of 2021, Also, international research evidence indicated that long COVID does occur in adolescents and children, presents with symptoms largely similar to those in adults, can fluctuate or reoccur, can severely impair daily function, and can last for several months. The most helpful survey of the Office of National Statistics suggested that the prevalence of long COVID in children and adolescents, however, is lower than that in adults. Importantly, among pediatricians as well as child and youth psychiatrists, it became clear that long COVID has to be differentiated from long lockdown, synonymous to long pandemic syndrome, the psychological sequelae of the numerous restrictions due to the pandemic. However, in 2021 and 2022, no pediatric case definition was available. The WHO only stated that a separate case definition might be applicable to children. With the German Society of Pediatrics, DGKJ, we agreed on using the definitions provided for adults with the well-known differentiation between long and post-COVID for sequelae later than 4 and 12 weeks, respectively, in people with confirmed or probable SARS-CoV-2 infection. For research use only, the UK CLOCS consortium suggested to focus on confirmed cases only, which of course might have excluded patients with false negative tests from some studies. It was only in February 2023 that pediatric WHO experts published their consensus on a pediatric clinical case definition. As for adults, requirements included a history of confirmed or probable SARS-CoV-2 infection and, importantly, an impact on everyday function. However, the WHO experts decided to require a symptom duration of only 2 months for the diagnosis, which definitely facilitates timely pediatric care. Symptoms have to be present during the first 3 months, as in adults, may be new onset following initial recovery from an acute COVID-19, or persist from the initial illness and may fluctuate or relapse over time. Importantly, some experts suggested not to include the post-intensive care syndrome or sequelae of MISC into the case definition, which we think makes sense, but was not definitely consented. The lack of the WHO case definition was not the only challenge in pediatric research. Study designs were very heterogeneous. Larger cohorts were usually only using surveys without medical visits. Moreover, surveys usually provided only proxy information by parents. Clinically evaluated cohorts usually only included a small number of cases, and only few studies provided controls, which generally is a problem in pediatrics due to ethical issues. Only few studies performed longitudinal analysis and thus cannot tell much about severity and recovery, usually due to a lack of resources, unfortunately. And little information was available regarding disease severity all over. However, the door to evidence is opening step by step. Of course, the most burning question was about, also a burning question in the STIKO, was about the prevalence of long COVID and post-COVID and SARS-CoV-2 infected kids. The STIKO had tough times to decide whether COVID-19 sequelae might qualify as argument for vaccinating kids. Taken together, the few controlled studies here shown in orange available in general indicated a lower prevalence of long COVID, post-COVID compared to non-controlled studies. Some, however, with a relatively large case numbers here shown in blue below for interested people. An umbrella review from the ETH in Zurich suggested a prevalence of 2 to 3.5% in non-hospitalized children, and a Danish study suggested a prevalence of only 0.8%. However, the well-recognized CLOCS study from the UK cut the line of 10%. A precise estimation of prevalence is still challenging, not only due to different case definitions and study designs. Data were published from different countries, which all experienced different dynamics of the pandemic. The data were largely derived from cohorts recruited early during the pandemic and thus do not reflect the impact of vaccination or of more recent SARS-CoV-2 variants, as Tobias just pointed out. And last but not least, false negative SARS-CoV-2 tests in control groups, as well as underrepresentation of severely affected kids who might be homebound or even bedbound, and the exclusion of kids turning 18 years old in follow-up studies might have resulted in important biases, even in very recognized studies. Good news is, until now, that children, especially young children, are at lower risk to develop long COVID, post-COVID, to suffer from lower risk to suffer from activity limitation, and to get chronic disease with a duration of more than 3 or 11 or 12 months less often. However, when comparing the data from November to March, this is the last release, from the all-over prevalence of long COVID was lower in all age groups, but more children were reported with significant activity limitation and with a chronic disease over more than 12 months. And this is what we feel at our centers. Accordingly, pediatric post-COVID teams are still busy with a significant number of affected kids. The upper figure is showing the well-known waves of the pandemic by RKI numbers, split up for the younger age groups in different colors, age groups which are relevant to our center. Below, you find the numbers of patients within these age groups seeking admission at our center. The curves show some parallelity, but importantly, while the case numbers reported by the RKI declined, the number of cases seeking admission at our center remained at a significant level. As in many other long COVID centers, the management of applications and the offer of care is largely depending on extra budgets, which in our case was kindly provided at least transiently by the Bavarian State Ministry of Health and Care for about a year, and hopefully will be provided again during the next year, at least we have applied for. Long COVID in children shows similar symptoms as in adults, some of which are listed at the WHO description. And the WHO stated that symptoms more frequently reported in children and adolescents with post-COVID condition compared with controls are fatigue, altered smell or anosmia, and anxiety. Fatigue was also identified as symptom with the highest incidence rate ratio when pediatric data from German health insurances were compared by a team from Dresden for children and adolescents with and without a history of COVID-19. In a pediatric meta-analysis, fatigue was outranged by mood issues, indicating the importance of interdisciplinary diagnostics. This review also identified exhaustion intolerance as a frequent symptom. Many kids with exertion intolerance suffer from PEM. Tobias talked about it and Carmen yesterday, which is frequently observed in long COVID and can severely impair physical function and social participation. It is defined as a worsening of symptoms after activities that were well tolerated before. It feels like a crash or collapse and often manifests 12 to 48 hours after activity, which is tricky because you don't know that you will crash, lasting for days or even weeks or even months. It can differ inter-individually with regard to trigger, severity, trajectory over time, and the most bothersome symptoms. PEM is diagnosed by standard medical interviews based on validated questionnaires, and was validated by repeated exercise testing for research, which we should not apply to patients due to the risk of worsening the disease. However, it is the cardinal symptom of ME/CFS. Tobias just mentioned it, but let me come back to the very important clinical case definitions. Long COVID in children, let me see where I am. We have the IOM case definitions broadly recommended in the US by the CDC, and the CCC, Tobias pointed out, which we recommended in Europe, especially for research. Actually, we use both and compare them in our research projects. Both criteria require fatigue for over 3 in children and more than 6 months, which is of new onset, not explained by ongoing unusual excessive exertion, not relieved by rest, and not prevented. Post-exertional malaise in addition, and sleep disturbance. And then the IOM requires at least one of the additional symptoms 4 and 5, and the CCC at least 3 or 5 of the lower symptoms. Post-viral ME/CFS is known for decades, including pediatrics. We have outbreaks all over the world for decades. And in pediatrics, 80% of ME/CFS cases post-infection were observed, half of it post-Epstein-Barr virus-associated infectious mononucleosis. In prospective studies on adolescents, we found prevalence of ME/CFS in the US around 10% after 6 months and 12% after 7% after 12 months, with the fortunate notion that people recover. It is not that fortunate with students as shown below. However, the IQWiC presented most recently estimated case numbers for Germany, relying on publications from the US, which you can wonder how well they fit in Germany, but there was nothing better. And finally postulated something around 70 to 19,000 adolescents aged 6 to 70 years affected. The prevalence of pediatric ME/CFS post-COVID is not known. From the US, from the center in Baltimore, who has a long-standing experience on ME/CFS, one case was published aged 19 years. However, we definitely diagnosed 30 cases so far, aged 11 to 25 years, and we know of other cases in Germany. An increased prevalence of ME/CFS due to the pandemic was indicated in that paper from Dresden. Carmen mentioned it yesterday, suggesting increased rate from 0.2 to 0.6%. There was also a report of the National Association of Statutory Health Insurance Physicians for all age groups, which indicated an increase from 350,000 to 400,000 to 500,000 after the start of the pandemic, and now we have 2023. And moreover, there are some case reports from the Charité and from other institutions covering for very severely ill patients who see ME/CFS in about 10 to 40% of the patients. The impact of ME/CFS in children and adolescents is immense. It was shown to be the most frequent cause of long-lasting unexplained school absence. Remarkably, the health-related quality of life is lower than that reported by peers with other severe chronic diseases. It can lead to social isolation, depression, and in adults, suicidality. And of course, socioeconomic sequelae for families are significant if one parent stops work to care for the kid. Candidate risk factors are similar in post-COVID syndrome and ACFS, supporting the relationship. Older age was reported for both female gender, pre-existing health issues, and for post-COVID, moreover, acute hospitalization for EBV-associated ECFS, days in bed during the acute phase of the infection. For post-COVID, in addition, a pre-Omicron variant and no vaccination, and for ECFS, early autonomic dysfunction. Good news is that most children and adolescents recover from post or long COVID within 3 to 4 months, with rather 3 months in the very young kids. And at least in ECFS, 2 cases resolve within 10 years with a median disease duration from about 5 years. We are very happy that some pediatric networks could be established. Our network in Bavaria, a national network triggered by the Cover Child initiative of the NUM, and an international network including colleagues from many countries. We need a stepped approach to symptom-oriented, personalized diagnostics. Why personalized? Because the patients show different symptoms, and we have to prioritize. And also there are patients who do not tolerate comprehensive diagnostics. So at step 1, basic diagnostics should define the main symptoms, PEM, severity, participation, disease duration, risk factors, and then indicate medical needs. The second step might extend the diagnostics. And at the third step, experts should take care of the very severely ill kids, also maybe making use of telemedicine or even home care. And of course, we should care for research at this level. Most importantly, we should take care of the full spectrum of the disease, not only of post-COVID, but of all post-infection syndromes and of post-vaccination syndromes, post-vac, as well as for any other kind of ECFS. We should support cross-sectoral communication wherever we can. We therefore have developed a digital application to pediatricians in their office. And without any question, we need interdisciplinary teams with expertise on soma and psyche. Most recently, a group from Essen reported that only 30% of the patients who seeked help with suspected long COVID were provided with a confirmed diagnosis, indicating that we have to fish out many other disorders. And last but not least, we must not oversee severe orthostatic intolerance or even POTS, because this condition might impair kids' life significantly. They might not be able to take part in school just because they can't keep the upright position. However, we need not only in diagnostics, but also for therapy, a holistic approach to supportive, personalized management. And it's absolutely not true that we can't help. We can help a lot when we educate patients about the disease and about research knowledge. We can help by instructing in good self-management, including pacing, breathing techniques for those who have respiratory disorders, relaxing techniques, sleep hygiene. And then, of course, we should make use of any option in the field of pharmaceutical treatment, which is always off-label in pediatrics, not only in ECFS, and of non-pharmaceutical treatments, including medical aids, as far as appropriate. The Australian cohort I mentioned earlier indicated that paying attention to social learning needs and educational support have been identified by young people as being of similar importance to medical management. This is what we feel every day. We spend a lot of time on school issues, education issues, talking with teachers, and most recently wrote a letter to the KMK and asked them for help. Just to make a little point about our research interests, we are aiming at a very thorough clinical phenotyping of our patients, including patients with ECFS and post-COVID. We also established 2 registries, which are multi-center, involving also the Charité and many partners of the NUM. We are aiming at identifying biomarkers, elucidating the pathogenesis, identify patient needs, and have some pilot models of care and collaborate closely with the Charité on experimental treatment approaches. Well, taken together, there is a couple of things going right, including the announcements of the German government depicted above. And also we get some important kind support from politicians, but many needs are still unoverseeable. We need the competence centers, we need specialized regional institutions, we need telemedicine and home care in a comprehensive and budgeted way. We need adapted rehab programs, and we need academic education issues to get solved. And as Tobias mentioned, we need long-term research funding. Information on post-COVID, post-VAC, and ECFS in Germany was provided by us and others, and hopefully will by far be even extended by the BMG initiative Long COVID, Professor Lauterbach announced yesterday. Thanks to my team, thanks to all partners, thanks to the sponsors, and thanks to you for your kind attention.
Yeah, thanks, Uta. Are there questions? I mean, I would have one question for ME/CSF. We heard that more females are affected than males, and that hormones might play a role. I know that we only have a few patients before puberty, but before puberty, is it the same in girls and boys, or is there a difference?
Oh, thanks for that important question. Thank you for the important question, because no, it's not the same. So before puberty, there is a sort of equal ratio. I mean, so the female predominance starts with puberty.
Yeah, I mean, we also see it in multiple sclerosis and in other autoimmune diseases, so I think it really plays a role. Yeah. Okay, yeah, if there are no further questions, Uta, thank you to you, and also to all the others who gave insights to us on post-COVID, and we heard the broad spectrum, and we also are aware that there is still a lot of work to do in research and also in politics. So thank you for coming, and have a good way home.